you could tell that these are very thoughtful students. You have very thoughtful students, and if these are going to be like the leaders of academia 10 years from now, 20 years from now, I feel like if this is going to be just a snapshot, I feel like we're in good hands, because they're asking some really good questions.
How often do these ethical situations come up, and how often do we have to stop and consider ethics in our line of work? All the time. So I remember in medical school and preparing for my boards, we have these like ethical prompts where it would be, the Jehovah's Witness example, things about people making decisions on behalf of other patients. And I remember learning this in school and thinking, this can't possibly happen as frequently as it seems to be tested. And it happens so much more frequently. Like it is such a problem. Problem is the wrong word, but it's such a present part of our day-to-day life that this stuff, you don't even think of it like, oh, this is an ethical quandary, because it's just like part of the job. And in terms of like, how often do we consider ethics? I think all of us are juggling the 4 pillars of medical ethics every day with every patient, whether we actively think about it or not. Particularly the beneficence and non-maleficence. I think we're constantly, when trying to figure out how to treat our patients and trying to give them recommendations on what we think would be the best way to progress their care, we're always thinking about, how do we, promote healing and health, and then make sure that we're not, inducing harm. And that's a pretty delicate seesaw sometimes. And certainly autonomy and justice, and we can talk more when we get into the surrogate decision maker stuff about autonomy, but that comes up daily, particularly in internal medicine, because a lot of my patients are older and some of them have dementia. Injustice in a big way in the outpatient setting, still in the inpatient setting, but we constantly have to be navigating, does this person have access to healthcare? Like, what is once we treat them and get them out of the hospital, then what? How do we set them up to success? Do they have like barriers to care, and what can we do now to try to tee them up as best we can so they don't completely fall off the map when they get out of the hospital? It's a bigger issue for sure in safety net hospitals, of which mine is not necessarily, but it still comes up. So yeah, ethics is a integral part of my day every day, whether I'm actively thinking about it or not. And I think that although we learned the 4 pillars in medical school, they're so seamlessly integrated into our workflow that we don't even really stop to think about them.
Quick follow-up, what's a safety net hospital?
Safety net hospital would be either county or state funded hospital, or a hospital that has a high proportion of Medicaid patients. So most of their patient population is below the poverty line.
So do hospitals they don't open and they're like, we're going to serve the underpoor communities? Is it more like this is an old hospital and now it serves the underpoor community?
Somewhat. Some of the county hospitals, so like Cook, I'm in Illinois and in Chicago, so Cook County Hospital is the obvious example. That is a sort of county and state funded hospital specifically designed to ensure that if people don't have the ability to pay elsewhere, they can get the care they want there. Without getting too much into the weeds, there's a set of laws called EMTALA laws that dictate that we treat people regardless of their ability to pay in order to stabilize them. But once you get past the point of stabilization, and that could happen immediately in the ER, that could happen 3 weeks later in the ICU, when things become not an urgent or emergent case, not that people are looking to not treat people based on their ability to pay, but that becomes an issue at private hospitals or big, large private hospital networks. Will say, okay, you're stable now, you need your gallbladder taken out eventually, but you're underinsured or uninsured, so that's going to be complicated. You'll have to work that out with the surgeon, who might even be a private surgical group like contracted at the hospital. It gets very complicated. But at a place like Cook County Hospital, doesn't matter. You're covered 100% regardless of your ability to pay beyond that stabilization point that is legally dictated by EMTALA laws.
I think the single most common experience that you face is when you disagree with a patient's choice. Like it's not something that you would choose for yourself, but you still have to respect it.
The most common ethical problem is a patient who is unable to make their own decision for whatever reason, and they have surrogates that are either not available, not present, not identified, unable to make decisions, etc.
Surrogate decision-making, people having questionable decision-making in terms of best interest versus what the patient would want, or people just not having a decision maker.
Most common ethical problem in radiology that I experience probably is unnecessary studies being ordered and what you do with those unnecessary studies, because ultimately that's more cost for the patient.
Feeling like some of my patients weren't getting the care that they deserved.
Family members thinking we are providing a patient an opioid in a manner that's not in an unhealthy manner.
Recently, the most ethical experience that we've had is the resource scarcity of COVID tests and whether or not which test we should give a patient.
Reporting child abuse.
It's you know, whether to take away someone's rights and autonomy, and whether it's time to commit well, it's the one that I recognize most easily as an ethical area. As Dr. Lanigan said, all your every decision you make is an ethical decision, but that's the one that constantly dings up in my head that I'm doing something that is ethically heavy.
What is the most common ethical problem? I feel like I hit very few ethical problems because I feel like if you think it through in a ethical framework, then the answer becomes clear and then it's comfortable.
Good answer. I'm out of that. What I'm getting is you should have a strong ethics foundation. Ethics classes are really important. Philosophy is very, very important.
You should take it several times, in fact.
I think what's best for the patients versus what the parents want is what we see the most.
The common ethical issue is data analysis, trying to figure out what's statistically significant and if it actually means anything.
To what extent should paternalism exist in medicine? Is something that I've found interesting because it went contrary to my comfort level. Just some evolution in my thinking that I went into. So I worked for a long time in primary care, general medicine, and got the opportunity to work here with palliative care. And I wanted to go into palliative care because I thought this was an important part of people's life, that they should have that opportunity to have a good explanation and a chance to voice their opinion, to not have a paternalistic hand telling them what they need to do with the end of their life. Seeing people continuing therapies long after those were beneficial. And so I went in, or started into palliative care completely anti-paternalism, and found it my strong point to be able to translate the medicine for patients so they could understand it, so they could make their own decisions. But I had one case that was so instructional to me when I was working with someone who was in the intensive care unit, had every organ system failure, intubated, liver failure, kidney failure, and had come into the hospital full code and gotten intubated, and had a chance. We got asked to come and meet with the patient or the patient's wife and daughter. The patient was unconscious, not able to participate, but not wanting to be paternalistic, I was asking the wife to tell me that it was that she wanted us to make him DNR. and she could not make those words come out of her mouth. So, and I was insisting on it. I was, you know, you have to tell me that this is how we're to treat your husband. We're gonna stop these interventions, and we'll let his heart stop if it stops naturally. And her daughter fully understood what we were asking and said, "Mom, this is what he wants you to say." And she said, "I understand that, but I can't say it." And I didn't know what to do. I mean, my naivety, I was insisting that she would say this. And luckily, so, you know, we went around the circle, had a good half an hour talking about it, and said, let's just step away, take a break from this. The pulmonologist is coming in here in a little bit. And thank goodness the pulmonologist was someone with a strong ethics background from the university. And he came in and we explained the situation. He sat down at the same table we had been at, same people there, and turned turned it into a paternalistic, I still at that time called it paternalistic, conversation of saying, this is what's going on. This is what we can do and have been doing for your husband, and this is what we cannot do and will not do. And she said, okay, that's good. And she was at peace. Her daughter was at peace. It was a beautiful conversation, beautiful. Just such a learning experience for me, you know, as well as the medical resident who I was supposed to be teaching this to. And subsequently, I've heard this being called informed assent as opposed to informed consent. I mean, so we're informing you what is available, what we can do, and what we're going to do. Is that okay? And so I learned in that situation, there is a time where paternalism is necessary, that some people need that helping hand to get to that point. And so I've tried to, after that experience, recognize when we're in those situations where a family member or a patient is too uncomfortable making a decision that is just too emotionally laden for them to come to an answer. And this informed assent is, I still think it's just a euphemism for saying paternalism, but I've tried to use it more now where I see a situation where I cannot accept. I know that internally I wouldn't be able to accept a different answer. And to put it out there as a true choice for you is not fair, because one is so horrible and one is the right decision. And I know that sounds paternalistic when I'm saying it, but you know, to say I don't think it's required to give options that are not true options, that it's okay to not list futile treatment as an option. And this is that same idea. So I do see now that there is a role for paternalism at certain times, even though I went into this totally, you know, explicitly in my head that this is what I'm working against.
So follow up. I talked to someone else about this recently, and the way I described it is like, you know, when I'm in medical situations, like medicine's really tough. For a layperson, it's really difficult. Like, I'm not an idiot, but it's still tough. And then on top of that, like when you're in the emotional, distressing situations and having to try and understand this stuff, like it's like, I often defer to experts. I would very often defer to experts. And it seemed the doctor I was talking to said, yeah, when that happens, when a patient's asking me, what would you do in this situation? How would you handle this? They should give their honest answer. They should give their, you know, informed, you know, opinion about these things. But, and that might be paternalistic, saying, hey, this is the right thing. This is the good thing. These are the futile treatments. This is what you shouldn't be pursuing. And so it's like paternalism, the place that paternalism has seems to be in this, like, when asked for advice, that's when paternalism is a good thing, or when a patient is struggling to come up with, give an answer, then it seems like paternalism is a good thing. But as a policy level, like, hey, this is how the medical community should be, that's bad idea. But like in the individual interactions that you have with the patients, it seems like paternalism isn't always a bad thing, at least.
Right. In my readings for ethics not too long ago for the ethics committee, and I stumbled on a very simple historical review that really patient autonomy is a relatively new concept. That
Yes.
in the time of Hippocrates, you just got the treatment, and up and through the 1800s, the doctor knew best, and this is your treatment. There was no, tell me what's going on and tell me what's happening. And it really wasn't until like the World War II and medical interventions on Blacks in the South that it became recognized that, hey, maybe I can't trust medicine overtly, and I need to be informed. And autonomy, and then there was the political philosophy stuff where autonomy and understanding things and talking things out developed more over those last 100 years. So it's interesting that autonomy is a new concept that so we're still getting comfortable with it.
If there's already effective treatment, is it ethically justifiable to use a placebo control group? And the answer is, it is not justifiable, right? And we don't anymore, right? So there's standard of care, and standard of care has to be the placebo group. And what they've actually gone to is something called adaptive trials, which are basically you have a standard of care group, and then your experimental treatments, you have multiple experimental groups. And if one experimental group starts to fail, because you're analyzing this in real time, right? Those people have the option to switch to another treatment group. So you're not just withholding care, because obviously if it's life-saving care, you can't put people in that group knowingly and withhold it. So
have you ever given a patient a placebo simply because they wanted treatment?
No.
I've never given someone a like just water and told them it was a medication. However, I've given someone IV Tylenol and told them it was Offermev, because that's the name on the bottle and that's the name of the drug. And people think they're getting Offermev, not IV Tylenol, and therefore they think it works so much better.
I have given normal saline in lieu of a benzodiazepine for somebody who had a known diagnosis of pseudo-seizure and was exhibiting signs of not a true seizure. So you tell them you're giving them an IV benzodiazepine, and they actually stop seizing when you don't. But that is for a very nuanced situation.
I have never given a patient a placebo because they want a treatment. I have used the power of suggestion to emphasize the effects of the medication before, in hopes of eliciting some of the power of the placebo effect.
Well, so I've never seen it happen in our urgent care, but I've certainly heard of story. I mean, just look at how many patients prescribed ivermectin, that's essentially a placebo. So
not necessarily placebo, but medications that can treat their condition, but with minimal side effects or impacts on that condition.
No, but I've given them treatments for other things that they thought worked for something.
I'd say I've given pain medications as like Tylenol and ibuprofen instead of like narcotics.
I once gave mouse Fruit Loops and they love Fruit Loops.
So this is interesting because when I was in college and when I take my standardized exams, one of the answer choices is always go to the ethics board. So I thought there was going to be this like omniscient, like dark room with candles, and it's like the ethics board and they're in robes, and that's not the case. I would imagine this looks different at every hospital and every health network. The way it works at our hospital is we have a clinical ethicist So it used to be this gentleman by the name of Dr. Clint Moore. He just retired recently. He's an exceptional human being and was a phenomenal teacher to us about sort of ethics at the bedside. But there's a clinical ethicist whose job it is to help navigate sort of these complicated ethical situations. So when we put in an ethics consult in our hospital, it usually goes to that clinical ethicist. And there is a ethics committee, of which I think I'm technically part of, but they haven't been meeting that frequently because of COVID. But they don't sit and sort of talk about like, oh, we have this, like the book First Do No Harm that we had to read for Father of Science class. They don't sit and then once a week like talk about the ethical quandaries in the hospital and like give recommendations. They more look at as a sort of systems approach, like is our network and our policies and procedures in line with what ethics would dictate. So if you have like a patient issue, typically what happens is you'll consult the clinical ethicist, and often they will involve risk management because typically the legal implications and the ethical implications overlap a lot, especially if we're talking about trying to get a judge involved or petition the state or do any of those things. I'm sure there's more complexity to how that works, like from their level, but from our end of things, typically we bring the ethicist on board. They'll usually come on rounds with us in the intensive care unit, and they'll help guide us through sort of things where the ethics are a little confusing.
Yeah, so I'm currently an ethics fellow, so that is my entire job. I take 4 weeks of call, and amongst the other ethics fellows, we get ethics consults, and ethics consults can be from anybody. They can be a request from the family, they can be a request from the physician, they can be a request from the nursing staff, from anyone. They can put in an order from the electronic medical record, and it pops up on our list. We do talk with everybody and make sure everyone is okay with us coming, because we oftentimes it's seen not necessarily as a taboo thing, but sometimes as a you come in and kind of help direct situations, and that is not always the most welcome. But as most people agree, 99.9% of the time, everyone agrees that ethics is a great thing. And it's your job to kind of go in and assess the situation, whatever it may be, and you chat with your ethical attending, so someone who's completed an ethics fellowship, and you talk to them about the basic four principles of ethics that I'm sure you guys have been talking about: autonomy, beneficence, non-maleficence, and justice, and how whatever situation pertains to those four principles, and which of the four principles is, the key for whatever situation. And then it gets discussed at our ethics case conference with like 70 different ethicists. And it's very interesting sometimes how different ethicists look at situations.
I'd say maybe there's a little bit of mental training, but mostly it comes with experience and time. So as a nurse practitioner, like I started off working as a nurse, and during the time that I was in nursing school, I went to a Jesuit college. And so they focused a lot on spiritual practice. They focused on embodying the whole patient, not just physical, but mentality, spiritual beliefs, cultural practices, psychological well-being, and all of those kind of Jesuit values. And I think that was something that set me up kind of for success as a nurse, that I was able to communicate well, I was able to empathize. I felt like I took great care of my patients, but I also had boundaries that I was able to, kind of separate. Sometimes it is hard. I still have problems. I had a patient die this week, and it was pretty devastating. And so it is hard not to get attached to them. But I think we're still able to kind of provide that empathy. And I've definitely gotten better the more experience I've had. And I think it's hard, as a nurse, you're at the bedside for 12 hours at a time with a patient. So you kind of learn to understand other things that are ongoing, not just the hospitalization, but financial stressors or social stressors or other things that kind of affect their behavior while being in the hospital, and, why they're not getting better or why they're pushing to be discharged or all those other things too. And so I think having that perspective was really helpful in becoming a nurse practitioner, because as a provider, I feel like I have a little bit more insight in assessing my patients. So like kind of empathizing with them, but also being able to assess for other resources and things that they need. But I think it's just something that definitely gains experience and time. But I think the Jesuit education, and I know, Tom, maybe you can understand that too. I'm not Catholic, but I actually really appreciated that education. I think it's a great background. And I think we looked at a lot of other things that, compared to some of my colleagues and peers, gave me kind of a leg up.
You said you learned some things through experience. Have you learned any boundaries and borders through experience, and if so, which ones are they?
Yeah, I'd say, I mean, it's definitely hard. Sometimes we have what's called primaries. So like, especially as a nurse, like you're a primary nurse for a patient. So every shift that you're on, you take care of that patient if they're in the hospital for a long time. And so it's really easy to get attached to families, you know, a lot, you know, you maybe know about all their other children or what they do for work, and you talk socially. And so it's something that I've learned. I often don't talk about myself. Like I don't talk about like having a partner or children or, you know, other things. I just kind of focus on, yeah, I can talk to the family and get to know them, but I don't share my personal life with my patients. And I think that's something I've developed over time, that I think when you're a young nurse, you're like, oh my God, yeah, no, I'm not married, but I want children. You really kind of get into things, and it's really not necessary. But I also think, you know, there are times that families, when they discharge from the hospital, they want to be Facebook friends, they want to have your phone number. And then that's, you know, you have to have those boundaries, because that's great if they feel like they trust you and they want to stay in touch. But the next thing you know, what if they're reaching out for unsolicited medical advice? And what if you give them medical advice and something happens? You know, those are the things you have to think about legally. Those are gray areas that you don't want to get into. And it's tough. Like I took care of an adult patient for a long time, and she was rehabbing after like a cardiac surgery. And we were very close. I was like a quote unquote primary for her for a while. And when she finally discharged, she's like, okay, I want your phone number. Let's hang out. And I was like, no, like, you're very nice. We have a great relationship, but I can't do that. So.
My favorite aspect of my job is communicating complicated medical situations to patients and family members, because I think I'm skilled at distilling down complicated topics.
Getting to help people deal with complex ethical issues is my most favorite part of the job. Being on call is the least favorite.
I really like taking families and patients through times that they consider their most difficult, and leading them to kind of the others through all of that, whether it's good or bad, and helping them kind of relate to what's going on and being happy with the result, even if it's not necessarily what we would consider a happy ending.
My favorite part about my job is the never-ending learning.
My favorite aspect of my job is the complexity.
The team approach in terms of meeting and helping, assisting a friend, a patient. Okay.
I'm not working anymore, but probably the least favorite part of the job when I was working is feeling like I never had enough time to do what I felt like needed to be done.
My favorite aspect of the job is helping patients.
Making parents feel more confident about taking their kid home and like taking care of them.
The favorite is being able to provide some symptomatic relief. And so patients are grateful for that. The least is giving people bad news, although I almost answered that as both, because sometimes giving people bad news, they still say thank you for the delivery and being honest about it.
No, in my field where you have a lot of not quite sure if it worked or not is when you have a intervention that clearly works, and you know that the reason that the patient got better is because of your intervention, and that is kind of like one of the greatest. It makes you feel like a genius, so it's fantastic. And least favorite is writing notes. Hands down.
I love providing education for families.
My favorite aspect of my job would probably be talking to people and learning about what they do in their research.
Is there a special type of training that mental training that physicians and nurses undergo to show both empathy and care for the patients without getting attached to them? And the answer is, I mean, they try to train certain things, and they train how to come across empathetic, but I think empathy is not, itself is not a trainable trait. People have varying degrees of empathy and being able to tune into other people's emotional states, and also that's what in medicine, that's why you see different people go into different specialties. A pathologist doesn't really require much in the way of empathy. Not to say that might not have it, but and the second part of that is really whether there's some training to have the empathy but not get too attached to your patients. And I mean, really, the fact is you do. It's not possible for humans to not get attached to other humans that they're taking care of. What essentially, and you know, and I've known, I mean, I knew, speaking of pathology, a good a physician I knew some time ago who was a pathologist, started out as a primary care physician and had to leave because it was getting too close, and she became a pathologist, which is the exact opposite essentially. But you absolutely do get attached to your patients, and then invariably at some point terrible things happen to them. You know, and in psychiatry, I mean, I've you know, there's an opioid crisis question a little later down, and you know, I had a kid who was, I think 29, who admitted 5 or 6 times, maybe 7 times, and always the exact same story. I'm ready, I'm done. And then, you know, in passing, I hear a nurse say, "Oh yeah, they found him in his apartment," and that was just the end of it. And I think that basically it's not unlike the way your body learns to do any kind of anything else. Let's say you know, when you play a sport, initially you understand the general concepts of it, and then as little nuances come your way, you start learning how to avoid them or how to engage with. And I think that's basically what happens. Little things start ringing bells, little, you know, sometimes little alarms go off as far as saying like, okay, you're putting a little too much of yourself into this, or you need to do this, you need to, you know, sometimes you need to be whatever it is. And I think that it's basically, it's just the natural. I mean, we can't not learn as humans. Even if we're not memorizing stuff, we can't not learn. And if, as long as you have the resolve to continue doing what you're doing, you will pick up those elements. And then sometimes you need to just, you know, go to Arizona for a week or something like that.
I thought about that question as well, and my belief is that it's okay to still, and I'm someone who cries at the puppy dog commercials and, you know, tears up, and so for me to be working with a family who I've just told, you know, that dad's got advanced stage cancer, I have to deliver the clinical news first. But, you know, there wasn't anybody that I worked with when I was in primary care that I had a long-term relationship with that complained that if I shared tears with them.
In terms of like short-term care, I was talking to a nurse earlier today, and she was saying that like one of the things that the boundaries that she set for herself in terms of answering this question is like, she stopped sharing things about her life with patients. And she's tried to make it clear with her patients, hey, like, I'm here, I love you, I'm here to take care of you, but like, when you leave, like, we're not going to be friends. So is there a way like that you guys have thought about, you know, compartmentalization in a certain sense? That way you're not overextending all the time with every patient?
For me, it's not as much of an issue because I'm in an inpatient unit. And you know, so most of my patients are short term, and I have had patients who said like, hey, you know, when I get out of here, we should do that. And it depends on how with it they are. If they're pretty, if they're, you know, if they're like totally not really cognizant, you just kind of ignore it. But if they're you know, closer to when they're time for discharge, or, you know, you say, you know, I can't do that. That's not something, you know, this is a professional relationship. But you know, it's not even that. And as far as sharing, there really is a range of that as well. There's definitely some things you don't share, but some people do, you know, do share more. And it's usually, when it comes to sharing, it usually comes to your own, you know, sometimes sharing with someone that you have been there to an extent in an emotional sense to you know, or at least making them realize that you aren't just listening to them, that you do understand to some extent, does help. And you know, and then there's varying schools of thought even within psychiatry. There's, you know, there's a school that believes that you should absolutely do that, and then there's a school that believes that you should keep a complete poker face and just listen to the, you know, symptoms and make, you know, just be very, very stoic. I think that also kind of fits with, you know, a personality kind of construct as well. But the thing that I was kind of thinking of even more so though was also when it comes to kind of like that level of like the paternalism, because, you know, what happens is sometimes you have patients who are kind of help seeking by personality, and initially you may or may not be aware of that as you're trying to understand your patient, you're building a rapport and see their patterns. You may not realize that, and you may act one way, and then as you see the patterns and understand them better, you know, you may have to intentionally be less open, you know, and a little bit more firm and colder, like, you know, if I might say, to you know, because it's for the patient's best interest.
And I would say I am a master at getting into somebody else's family, but not inviting them into my family. I mean, my wife gives me a hard time that I would get home earlier if I didn't know so much about my patients. But I do think that helps with when we're making difficult decisions, which we are on a regular basis, and that they feel, you know, the rapport is there. And so I don't have to take it home with me, which I really don't. I can be totally involved there and walk away from it. You know, very seldom do I carry the stress into the next room. There are certain situations where that happens, but, you know, only intensely. So I think that, you know, it's something that you, like a muscle. I think Eugene's analogy about it being like an athlete, you learn that I have to deliver this amount of information, then I can share and take in other things. And yes, you can be empathetic there, but yeah, where do you learn that you can't carry it with you when you move on to the next patient? Some of that's speed, some of that's volume, some of it's the muscle that you learn to use. So,
and in the end, it's all about the patient. You know, it's funny, the 90-10 rule from sales fits very well into medicine, and that meaning that when you are in your interactions and conversations, it's 90% is about them, 10% is about you, but only in a way that relates back to them. So yeah, I will share something about myself, but only in the method, with the purpose of getting a better connection to the patient and getting more, you know, valuable kind of information from them.
Yes.
Yeah, I don't have a good sense about this one. It's not an area of expertise. I would say society as a whole, and probably the larger upper scale people rather than the pharmacists or the individuals themselves. It's a complex issue, not an individual issue.
Pharmaceuticals, because they lied about the efficacy of how long things are going to last.
I would say the pharmaceuticals and the physicians have some responsibility for prescription.
I think given some of the things that happened, probably the drug companies and the FDA.
Yeah, from a theological perspective, you just touched on what is sin, and we're mired in sin, and in that exact, who takes the blame for it? Everybody can take a piece from that pie.
Oh, great question. I'm going to say the pharmaceutical companies, primarily because of their marketing schemes, have been what has driven much of the opioid crisis, because they would go into doctors' offices and provide lunches and provide all sorts of things, hoping that these doctors would continue to prescribe them. And that is morally wrong.
I think the companies who made the drugs and ultimately got approval and mass appeal with wrong information.
The drug cartels.
Eugene.
I don't know fully the drug cartel, except for the, obviously providing heroin once the people are addicted. Most morally responsible. Yeah, I guess, yeah, I think I would agree with that.
Drug cartel did not mean big pharma, though.
No, pharmaceutical company was its own
Yes.
option.
Yes, right. Okay,
Yeah.
good.
Okay.
Pharmaceutical companies.
I'm gonna say pharmaceutical company.
I went to medical school in Morgantown, West Virginia, which is where West Virginia University is. I'm actually from the state, so I have a lot of, I guess, hands-on experience in that sense. To be full disclosure, I'm not an infectious disease doctor or those sorts of things. But we did a lot of work in medical school. So I think the most important thing is, and this is for any patient that has it's for any patient, but especially for patients that have substance abuse, it's like very non-judgmental, discussions with patients. A lot of times I'm like, hey, I ask this question to absolutely everybody, whether you're 89 years old, whether you're, 16 years old or 45 years old. And I go through, all the substances, also knowing like colloquial terms for things that, some people don't use cocaine, they use crack, but it's almost the same. Or, heroin, smack, using things that they understand. And that way, you can feel like a little bit more on their terms and less like you're their kind of parent or their physician kind of looking over their shoulder in like a derogatory way. You want them to feel like they could be honest with you. And the way I phrase it is, if you're interested in, having any sort of help or quitting, we're able to do those things for you. We're not going to like talk to you unless you really want it. And some people are very honest. They're like, no, I don't want to quit. And at that point, you have to respect their decision. The things I do say, if they are someone who uses IV drugs and they don't want to quit, I'm like, okay, that's totally fine. Are you interested in hearing out about how to use safely? And that's something I have like a whole speech on how to use IV drugs as safe as possible to like prevent infections, whether it be like local infections with the syringes or whether it's bloodstream infections and endocarditis or infection of the heart valve, those sorts of things, and like little things for them to watch out for at home to come in and see us. And then that way they at least feel like I've heard them and I'm saying, I don't care if you don't want to quit, but I want to make you safer at home, however you choose to live. And I think that really resounds well with a lot of, especially the younger population, because they don't want to quit, and that's fine. They're allowed to do whatever they want. But I'm just saying, hey, I see you, I hear you. Here are like 5 things that you could do. They're super simple and super easy and free that will make you not have to come and spend 4 weeks in the hospital with me again. So I think that's really important. And the opioid crisis overall, obviously, it's a very sad thing. And there's a lot of work now that I think has kind of slipped into the sense that we maybe undertreat pain a little bit, and we're coming back around to like treating pain a little bit better, maybe in more so in like a chronic fashion than necessarily an acute fashion, because there's lots of studies that have shown that like acute opioids for a pain crisis for like a surgery or something like that does not lead to chronic opioid use. But it's something that I think for chronic pain control, it has been really difficult.
Okay, so I do have one specific question, and this is actually kind of for everyone, just generally about how you see the opioid crisis. Like where do we stand today? Are we on the downslide of the 3rd wave, or are we, about to start a 4th wave? Like, is it going to get worse, or are we like, is it getting better? Like, what's going on?
That's a really hard question. And I feel like geographically, everything is a little bit different. Like there are certain pockets, which as we all know, West Virginia is one of them where it's worse than other places. So I feel like it definitely has a geographic pattern. I would say overall, I think things are getting slightly better, but I would agree with Dr. Luff that things need to be put on where this is a medical problem. And I think some of that shift has happened, but not completely. to be, have people come forward to get treatment because they don't want to have these sort of legal ramifications that often are put on them. So it's going to be a long time, I think, before the crisis is over.
I think that opioid addiction and substance use disorder should be treated as medical problems and not legal problems.
Oh, that's a tough one. It's a very contextual based upon what, the patient's history and everything like that. There's not really a good answer to that one. Those are super difficult, cases.
I don't know. That's so far from me that I don't have a.
I often wonder if we start seeing people for the view of being a child of God, in spite of their disease, they would see themselves as a valuable person, in spite of all the choices they made to lead up to that lifestyle and that addiction.
I think with compassion and resources.
Really treating each person as who they are and really learning and understanding who they are is the most respectful and appropriate way to treat a person with an addiction to any substance.
And I would say supporting substance abuse treatment centers.
I think with compassion, they started off doing opiates for whatever reason. And so showing them compassion.
I think the most ethical way would be to properly treat them with drugs that they need to remove themselves from addiction.
Yeah.
I'm a biologist, and biology incorporates DNA and how that eventually gets to the organism. So CRISPR is a great technology. I hope you guys talked about it decently well in the course. But did you guys watch Jennifer Doudna's talk or anything like that?
So I didn't have him watch any talks. I read her book and I took notes on her book, and then I presented her book. Yeah.
Oh, nice. I once saw her talk in 2015 in very small, super crowded room. And it was before she won the Nobel Prize, right? Big scientific lecture. Huge, the premier Biophysical Society annual, this is the lecture of the whole talk. She talked about her science for 20 minutes, talked about the questions and the ethical problems that lie with that for about 45 minutes, 50 minutes, because it does bring up so many ethical issues that who knows where the world can take it. And we need to establish education to figure out what is reasonable and what can be done with that. So let's see what these questions actually are. Where do you see the direction of CRISPR growing? It's super easy, super easy. My buddy, who's a molecular biologist, he picked it up in 2 months, just bought a kit online, $500, $2,000. With other samples they had, it was a fully functioning lab. So it's harder to do just out of the pocket in your backyard. But it is pretty easy to do. And I think everyone will start doing it. All the customers that I interact with it is basically what PCR is to genetics. PCR, for those that you don't know, polymerase chain reaction, essentially our COVID test amplifying DNA to read what DNA actually means. That is it's basically the newest tool that we can do to gene editing. It's not perfect, and there are lots of caveats that we've started to learn from that. But I think it is the step in the next Gattaca kind of revolution of our species.
So I assume most of this is you probably understand the difference between the germline cell and the somatic cell editing.
Yep.
So right now, no one's anti-somatic cell, and germline is the super controversial one. When it seems inevitable that it's going to happen, right? Well, so they did it in China. They edited a human embryo that wasn't implanted, and then they did it again in Oregon. So we know we can do this.
Yeah. Well, yeah. Biologists also found a way around that ethical problem
Okay.
Oh,
tell
I mean,
us.
they just you collect a regular germ cell or somatic cell and turn it into a germ cell. That one, yeah. So genetic reprogramming is like a huge thing, and basically trying to develop these tissues called organoids. So there's lots of cool people that try to look at how you can take a skin cell and basically turn it into a neural network. So there are biologists are getting around that. He's like, oh, it's not a germ cell. It's not. But
So we learned about in stem cells, there is some research showing that like we can take a skin cell and turn it into a stem cell. And I think that was in the early aughts, like 2004 or something like that. And so is that the same kind of idea you're thinking? Like
same exact idea, but easier, way easier, and like instead of like years, it takes like a few weeks or something like that.
Yeah,
to make that happen in a cell in a dish, not in an organism. And the cells that I'm talking about could be like they're like organized, they're tiny, nowhere close to organized organism. So we're not quite there, but I've just wanted that we are trying to navigate around those ethical problems, and that those questions will change once we have a new tool, that the new CRISPR that comes out, right?
Yeah. Okay. So, okay. Best guess. Do you think there will be a human born who will have had their germline edited in the next 5 years?
Yes, easily. Yeah, 5 years. Yeah, for sure. The germline. Yeah, I don't know if it will lead to any changes because there are so many other things that affect the organism once they are a single cell to a multicellular organism, and behavior and life and everything that goes along with it. But yeah, I totally think that they might have already been. You never know.
Okay, so I don't think my students believed me that CRISPR is so cheap. So you were just saying about your friend who bought it so he already works in a lab.
Yep.
Do you have any other stories like so? And then in comparison to the zinc nucleotides, I forget what they were called, but like what was also developed right around the same time as CRISPR. In comparison, in Dowdna's book, she said that it was like $25,000 for each one of the like zinc nucleotides, whereas like it was like tens of dollars for the equivalent of what CRISPR did in the
pennies.
Same thing.
Yeah, it's pennies on the dollar.
And one took months and the other one took minutes, maybe 15 minutes. So yeah, like, can you just talk about like the comparisons of like how much stronger CRISPR is than like other close technologies?
Yeah. So there are, so before CRISPR, in order to create a knockout animal, okay? So let's say we know cystic fibrosis is caused by this one CFTR gene. Let's just knock it out. Well, that probably won't work because no one will actually survive, but for the sake of purposes, you try to knock it out. And in order to get that in a line in a mouse, you have to use all the multiple generations. You have to raise the animal, you have to birth them, you have to raise them, and so forth. That would take 2.5 years just to get the 10 generation you need to get the stable knockout. Okay. With CRISPR, you could do it in 1 generation. So like instead of paying the animal people, you pay, I mean, for a cage. So I took care of a lot of my animals like halfway through my graduate career, but we were paying $45 per cage per day of an animal, of a rat litter. And you have what, like 30 cages? Some people have like hundreds and hundreds of cages. That's like what, like $30,000 a day. It adds up. It adds up.
Yeah.
So that's part of the cheapness of that. And then there's also the advancement of the nucleotides part. So you said the zinc nucleotides are so expensive because they need to purify them and make sure that they're functional. This just uses basic nucleotides that we normally have in the body. You don't need to add anything extra. You might need to add some free nucleotides, but.
Okay, so this is one I didn't see, and I'm not quite sure, and I'm not sure you're qualified to answer this question, but you're the only person I know who's excited to talk about CRISPR. So, do you know if CRISPR could be used to help any mental illnesses?
Okay. Maybe, not right now, probably. I think the current understanding of mental illness in the biological cellular context and like a mechanism of what we think mental illness is not fully known. So it's easy. So CRISPR is a gene. It makes gene editing really, really quick. Okay. So if I have a target that say, I know this gene, yeah, we can edit that. We can make that really quick. But the problem with mental health is that there's a lot more to it. There's society, there's behavior, there's other interactions from an individual, not just the individual itself, that we don't have the tools necessary to fully understand it right now, and we don't understand that.
Question. So, and I guess the idea is like maybe it's not directly, because mental, exactly what you're saying, mental illness is so hard to put your finger on. It's hard to like cure something that you can't really touch or define or whatever. But in the same way that CRISPR is being used to, you know, quicken the development of drugs and things like that. So it'll just help illness in general. And so it might help the development of the drugs, or it might help the development of something tangential, but it's there's no clear way that CRISPR could directly help mental illness.
There's not a direct way. It will definitely be a tool. And I totally believe that there will be scientists that will eventually try to target that. I think just our knowledge is just not there to solve that question at the moment.
Excited but hesitant. And I'll just say Gattaca. That's all I'll say.
Can I be all three?
I'm excited. But I'm doing bench research right now, so I have a different perspective. So I am excited.
Oh, both.
There's three, but yeah.
All three.
Well, what I wanted to add to that is a little bit, I'm very excited, a little bit scared, only because almost everything that we've created has also been able to be abused.
I can only say my first reaction is, just because we can, should we? But then again, you're making very specific, like sickle cell anemia, and I'm like, yeah, we should.
I originally went into UMSL wanting to be a virologist. I wanted to work with CRISPR and gene replacement therapy, specifically for HIV and cancer-related treatments. So it's really exciting for me.
Nervous.
All of the above.
Scared.
Terrified.
I work in pediatrics, and there are two current pediatric diseases which recently had the FDA approved gene modifiers to help treat the diseases. And there are talks about like maybe these could become cures for these diseases. So I think it's very interesting. The first disease that we treat, it's called SMA. It's a spinal muscular atrophy. And it is a degeneration of motor neurons within the spinal cord, and they can't make enough of what's called an SMN protein. And so the motor neurons, they need to create this protein to function, but they have a mutation or deletion within that gene. And so they can't produce enough protein, and then their muscles don't work, essentially. And it's the most common genetic cause of infant mortality, and it occurs in 1 in 1,000 live births. And right now, before this gene modifier came out, our treatment was just focused on supportive interventions. And so depending, you know, there's a spectrum of the disease, depending on how severe it is how long these children live for. Whereas some can die within a few weeks. Type 1, it usually comes out after birth to 6 months of age. They're never able to sit independently, and they die before 2 years of age. Type 2, the onset comes on between 3 to 15 months of age, and they may be able to sit later in childhood, and they live to about mid-20s. And then type 3, the onset is like maybe toddlerhood to childhood, and they may walk independently. And then type 4, they live an adult normal lifespan. But there's a new modifier that came out in 2016 called Spinraza. And what it does is it targets this SMN2 gene, and it increases the protein production within the gene, and it splices the pre-mRNA, and it increases the amount of functional survival protein. And it's initially given, the first 3 doses are given intrathecally, so like through a spinal tap. And you give the medication, and then you start to give the medication every 30 days and then every 4 months. And what it does is it just helps improve motor function. Children are able to meet their motor milestones, and they can start to grasp and kick and sit up on their own, control their heads. They can roll, they can stand, they can crawl, they can walk. And it's really been pretty amazing. And these kids, before treatment, a lot of them maybe needed like tracheostomy or ventilation. So they needed a machine to breathe for them because they didn't have the muscle support to be able to do that before they died. And now we're seeing that a lot of these kids may not need the tracheostomy, may not need ventilation, and their life support is a lot longer. And their quality of life is a lot better too, because they're meeting their milestones, they're walking, they're talking, they're doing things that parents never thought that they would see for their child. So it's only been a couple of years since it came out, but it's really amazing. And we have a patient right now that's been in the hospital for quite some time, but has SMA, and the things that they're able to do is so amazing. And we never would have seen that without this medication. So that's one disease that the gene modifier is just so cool. And of course, because it came out in 2016, I'm not sure like how that's going to change life expectancy, but it definitely is. And then the other one is cystic fibrosis, which more people are familiar with. But cystic fibrosis is caused by mutations in the cystic fibrosis gene, and it leads to defects in a specific protein called the cystic fibrosis transmembrane conductance regulator, or CFTR protein. And so this protein is not able to get to the cell surface where it should, or it doesn't correctly open when it reaches the cell surface. And because of that, chloride ions can't move in or out of the cells, and they cause like thick, sticky mucus. They build up in different organs, particularly the lungs, and it causes frequent respiratory infections and respiratory failure. Historically, cystic fibrosis patients have needed lung transplants, or they die in their 20s to 30s. It also causes pancreatic deficiency. Sometimes they get diabetes requiring insulin. They have gastrointestinal deficiencies. They're not able to absorb fat-soluble vitamins. They need enzymes with every meal. They're very malnourished. They can't gain weight. They have osteoporosis. They have low bone density. There's lots of different issues, all because of this chloride ion. And in 2019, there was a new medication that's another gene modulator that was approved, and it's called Trikafta. And it's a prescription medication that targets one copy of the F508del mutation in the cystic fibrosis transmembrane conductance regulator gene. And it targets up to 178 genetic mutations right now. And it helps these chloride ions appropriately function. Since we've started putting patients on this medication, we are seeing that their lung function is improving. Their sweat chloride is decreased. They're gaining weight. They're not in the hospital for pulmonary exacerbations. They're not requiring IV antibiotics to get over these exacerbations. And we assume that it's going to increase life expectancy. Most cystic fibrosis patients at this time live to be about 40 or mid 40s. And so we're really expecting that that's going to improve. And I work on a pulmonary unit, and we used to have majority of our population had cystic fibrosis because that mucus is so thick within their lungs. They get sick really easily. They get pneumonia very easily. It's very hard for them to cough everything out, and they're very malnourished. And so it's very hard to get over infections. And then if they have diabetes and need insulin too, it's just a lot of things working against them. And in the last 2 years, we have 1 or 2 maybe a month on our service. It's really incredible that we're not seeing them in the hospital. And then when we do see them, like their BMIs are way better. They're no longer underweight, or they're no longer requiring like extra nutrition through like a nasogastric tube or a gastrostomy tube. So it's really been incredible. And so kind of looking at like the original question. So potentially these medications would be something that we could maybe move towards curing a disease. But I don't know when we would move towards non-treatment ends per se, or like enhancing individuals. I don't know about any of that.
We have a best guess, like speculation. When does Gattaca become a reality?
I still think we have a long ways to go. Maybe not in our lifetime.
I personally think as healthcare, and maybe society at large, we have a harder time with letting people die. I mean, that's a struggle for us. If people want to do everything they can to keep a person going, for what motivation? For their own motivation, because they don't want to lose the person. So I think one of the biggest struggles in healthcare is for people to be able to have a peaceful death when it's appropriate. And I think Patrick and I have worked in a lot of situations where, peaceful death is the next thing that's welcome. And if you can be part of that process, keep the person comfortable, counsel the relatives who are emotionally wrought, and honest to God, I mean, I still recommend, and Patrick, it's still something that people want to drag their feet about, is hospice care. Because I think that's the greatest gift that has come along that we have to offer people as they approach that part of their life. And that's not only the person that's dying, but it's the relatives who are caring for the person, et cetera.
As you're sharing the views, a couple of things come to mind, and that is very much, I don't want to take away the right of one person. And I think, I don't want to go into a deeper philosophical conversation, but I wonder what the conversation would look like in terms of euthanasia if we lived in an environment where it was a bit more communal than it is based on like just individual. I don't know that I'm not a trained philosopher, but I just wonder if a person would feel a bit more, well, like Stephen Hawking. I mean, he was definitely cared for in his academic community. I mean, he had a purpose, and he happened to be in something that provided him a purpose. And I don't know. I just kind of wonder too, because we do live in such a very individualistic environment where the needs of one person sometimes even trumps or takes over the needs of a community. As a person who is a religious leader, I can't speak for all religious leaders, I can't speak for all religions, but if you look at the basic tenets of most faith groups, they are against euthanasia for different reasons overall. And the biggest thing is that, one, who gets to play God? I think you hit it on the nail. And the second thing is this idea, this life is important, life is sacred. Now that's an overall, that's just a generalized statement. So of course, like in Buddhism, there's many different tenets of Buddhism, but Buddhists generally would say they would not be for euthanasia because of the importance of life. But if you talk to different sects within Buddhism, that they would have a different approach or a different response.
So that's the idea, is like passive euthanasia is supposed to be like the disease is killing them, whereas active euthanasia is like it's human intervention that's killing them. But it's still, we could intervene and stop this. So we're letting a preventable death happen is the point. So it's still, we're implicit in the letting die.
Because as a hospice chaplain, especially when you talk to a previous generation of oncologists, and if you think about it, people still use this language today. Someone goes into hospice, they've given up. And so if we use that word passive euthanasia, then would that then qualify? Now I'm becoming like a student now. Would that qualify then would that be hospice? Because if you think about it, that's what hospice is. You're no longer, you're creating a bit more of a quality of life in that moment. And but I think that was a hang up for me, because I was thinking, why am I getting resisted to the passive euthanasia? And that's for me, that would be the struggle. I've not heard that before, so I have to look into that a bit more. So but to answer the question, Barbara hit it on the nail. I think situational. I mean, really, at the end of the day, a lot of situational ethics, to be honest with you. Now, I think somebody that may be a little bit more well-read and maybe a bit more well-spoken could probably have a 5-minute deeper response. But really, at the end of the day, they're also going to say, yeah, but, you know, if they're not really living life, that's going to be challenging. And I think that's part of the challenge, which is a whole nother question. Unfortunately, this is where I think some students may agree with me. Unfortunately, religion begins to start to pontificate. And instead of moving into a different realm of providing what I would call pastoral care, spiritual care, faith language, just creating a space for people to have and grieve in that space, even though it may not be the perfect response or may not be the perfect decision. But then again, we're imperfect people. I believe we're imperfect people. So we're going to make imperfect decisions. And unfortunately, this is where denominations, religions, faith, this is where people start to pontificate, and then it becomes doctrine, and not necessarily faith language and heart language. Well, and yeah, it's interesting because there's always going to be that tension between the heart and the head. Mm-hmm. And also to just familial pressures, societal pressures of what society tells people what's right, wrong, and indifferent. And just some people are just not ready for it. Emotionally, they're just not ready to say, but academically, because they're standing behind some pretty big giants. I had a professor, my bioethics teacher, he always said the best thing to do is figure out what, as best as you can, always ask what's the motivation behind it. What really, truly, what's driving the impetus behind wanting to remove somebody from a feeding tube or the oxygen, because removing that device that's not the act. That's from a faith perspective, that's not going to be displeasing, or is it going to bring pleasure to God? It's just the act of removing something that we created. What is pleasing to God is, why are you doing it? And Barbara, you hit it on the nail, and Tom, both of you are like DNR, okay, figuring all that out. They kind of have an idea of what's happening. And two, what does the person want? So.
No, I think death is an inevitability just as much as birth. And I think it's our job to both preserve life, and then also when it gets to that moment, as physicians, we need to facilitate death in a dignified and comfortable way.
No.
Death with dignity is a wonderful thing.
No.
I mean, sometimes death is the best thing.
No, death can be a great thing, especially not only in terms of it relieving somebody's anguish, but also it's a personal choice. And so if you would prefer that your end be a certain way, then that's the way it should be.
No,
it's just a thing.
No, there are far worse things that we do to people than allow them to die.
No.
I was intrigued by this question about that philosophers and bioethicists argue about the difference between passive and active euthanasia, because in clinical medicine, there would be no argument. There's no such thing as passive euthanasia.
Right.
My reading about it is acknowledging that it's essentially allowing a natural death. And we fully believe that allowing a natural death is acceptable and a comfortable plan. So I was sort of taken aback that, well, I guess I can see how on a ivory tower philosophical standpoint you could argue it, but in practicality, it's fully legally and ethically acceptable to allow somebody to pass away naturally. And so to call it a passive euthanasia is only to stimulate an argument, in my belief.
I think the idea is not necessarily the letting someone die naturally, but like the instances where it is you're pulling the plug. And so you're still doing something, but then letting them die, but you still have to do something to let them die. Whereas, a DNR, you get a patient in who's already unconscious and like, then you don't do anything. That's clearly letting them die. And that's kind of different than the pulling the plug. And some people think the pulling the plug still is like, it's euthanasia, but it's still very, very morally permissible. And still slightly different than the just naturally letting die. But then it's very different than the active euthanasia, which is giving them, prescription drugs or whatever to, help in that process. But yeah, most people, they use that distinction to say, okay, there are different, like the pulling the plug, morally permissible, the other kind, not morally permissible. Or that's how some people see this moral permissibility or impermissibility there.
I think autonomy is important. I don't see how you could not tolerate them, right? People have the right to explore whatever treatment options they want, so long as it's not harming, like actually doing imminent harm to them. And even in some cases, I guess that's a whole rabbit hole that we don't need to jump down. But in general, if they want to explore, essential oils or a lot of times people just call it holistic therapy, which is kind of misusing the term, honestly. But that's what they call it. I remember my intern year had a patient died from pretty bad lung cancer because they refused treatment and instead decided to explore all these alternative routes of herbs and things like that. And ultimately they ended up in the hospital and dying in the hospital because by the time they decided that wasn't working, it was too late, right? So it's hard to watch, but I don't think we can prevent it. I do think the real duty of physicians and medical providers is education, right? So you have to educate the patient about, this is not a proven therapy. There is no evidence that this is gonna work. Educate them on the therapies, the benefits of the therapies, obviously the risks of therapies as well. But I think education is where we need to focus.
Yeah. I did find it really fascinating. Now I understand these are you could tell that these are very thoughtful students. You have very thoughtful students. And if these are going to be like the leaders of academia 10 years from now, 20 years from now, I feel like if this is going to be just a snapshot, I feel like we're in good hands because they're asking some really good questions. I did have to find it funny though. Number 7, should alternative medical practices be tolerated? Prayers. I didn't know prayer was a medical practice. And yeah.
Was that parenthetically part of? I didn't see that. Funny.
Yeah. But it's really interesting though, because even in a hospice setting, you actually get doctor's orders to go visit a patient as a in my discipline. Now, what takes place in that visit is completely different. Whatever, any medical director is going to say, well, you know what you're doing. But I never saw it as I never saw prayer as a medical practice before. So I would.
But it's an adjunct. I don't know if I'll say treatment, but it's an adjunct approach, just the way that, massage, or and that's more commonly accepted now, Tom, than it was 10 years ago, to have Eastern and holistic treatments being considered as part of a medical treatment. So it's not an either or so much anymore. It's let's do this together.
There are interesting questions like what you're talking about with prayer and praying with a patient and things like that, and massages and even meditation. Essential oils, I don't know, I'm iffy on, like, if you really think it's curing your cancer, then it's like, okay, that's a bad idea. But like, if you think it's like, it helps you breathe better if you put it in your humidifier, it's like, absolutely, I'm fine with that. But when you're talking about Christian Scientists thinking that like prayer is, or that disease can be cured by prayer, like, is that some sort of religious practice, some sort of alternative medical practice that should be tolerated? That's like, what do you think about that?
Well, that's a whole, they don't go to doctors. So it's not even like you're going to be in a position to be recommending anything. They don't believe in medicine, right? So they're going to go to their Eastern practitioners who do acupuncture, and that's the limit of what they're going to even be willing to look for the most part. So I doubt you're going to find them in a position where somebody's offering them chemotherapy. But if they are, then you offer them what you would anybody, and they say no or yes, depending on how they feel at the time.
Either the ECMO cases of rationing and futility, or cases around brain death or withdrawal of life-sustaining treatment after suicide attempt.
I had to bar a patient's significant other from coming to the hospital because we were afraid that they intentionally overdosed this patient while they were admitted as a patient at the hospital.
Most intense ethical problem I could think of is during medical school, medical students were only allowed to deliver uninsured babies.
That is, I don't want to take any medication because Jesus suffered on the cross, so therefore I have to suffer. And to me, that's not biblical. That's not scriptural. So to help with that ethic of what it means to suffer, and to frame it in a way that's a positive situation.
I just zeroed in on the most intense experience, which isn't necessarily to me ethical. It's to be present with a person who's dying.
Probably when we made a HIPAA violation at a healthcare organization. That was part of my team. It was my team that made the mistake, and we had to rectify it. Somewhere around 6,000 to 10,000 patients were affected, and of course the government gets involved, and so we had to work together to figure that out.
Pursuing interventions in the NICU when you know that it is likely hopeless.
Family members being uncomfortable with having to make the medical decision for a loved one.
Honestly, I think it kind of just happened very recently, and Dr. Lanigan's aware of it. We had an instance where a patient consented to a set of procedures that have the risk of causing confusion throughout the process, but they were able to consent at that time. However, in the midst of the procedures, the confusion started happening, and they were no longer in a mental capacity to be able to say either keep going or not. So, and typically the process would involve continuing the procedure, assuming that you believe that it is going to be effective. But there was also, it wasn't that clear. It was murky. The way he presented with the confusion was a little different than what we'd seen before. Now, in a typical case, what you would contact the family as a second decision maker. Unfortunately, there was an actual ethical case brought up against the family with concerns of them taking advantage of this patient. So there was there was a concern that we wouldn't be able to ask the family because they might not have the patient's best interest in mind. So that was probably the most complex conundrum I've ever dealt with.
We recently had a patient where he was on a ventilator and parents did not complete all the education to take him home, but parents felt like they were prepared to take him home. And unfortunately, he passed away.
The biggest ethical problem is dealing with experiments on animals. I personally did not want to do that.
I've seen on social media that students will perform pelvic exams on women under anesthesia for educational purposes without woman's express consent. So I wasn't familiar with this. And what first came to mind for me was I did do a pelvic exam under anesthesia in medical school for a gynonc procedure. We were removing, it was a hysterectomy. It was transvaginal, and the patient was very aware that I would be involved with the procedure. And also the pelvic exam was very much a crucial part of the procedure. So that's what I kind of thought about at first. So then I looked it up, and it looks like people, there are cases where residents and medical students were performing pelvic exams during surgeries that were actually unrelated, like where the pelvic exam otherwise was not indicated. And I think that's battery. I don't really think there is any excuse for that without consent of the patient. I just think, I mean, it's flat out not excusable. I think you'd have a hard time finding anyone who'd disagree. Obviously someone disagrees because they allowed it, but.
Can I ask a follow-up question?
Sure.
So for those of us who are ignorant, how invasive is a pelvic exam? Is it just palpating someone's pelvic region, or what does it involve?
Yeah, so it is invasive. Fingers go in. Obviously, they're gloved. It was in the sterile operative environment. So in this case, it was actually a transvaginal hysterectomy. So like the uterus was being taken out through the vagina. So the pelvic exam was very important. I mean, that's where all the work was being done. So it wasn't like, the patient had every expectation that hands would be there. But you know, the case I saw was a patient apparently having like an abdominal procedure unrelated. And the resident afterwards told them that they had started their period and they discovered it during the pelvic exam, which was
surprising.
Indicated. I mean, there's so many missteps there that I think it's hard to justify. So
yeah.
So we have patients with dementia. We have lots of patients with dementia. And there's a huge deal of variability to someone's cognitive capacity when they have dementia, and there's lots of times when you have someone that isn't able to communicate, but they are grasping a lot more than it seems. And there are times when someone, may not even be oriented to where they are, or maybe even their own name, but they can very clearly voice their long-standing beliefs and philosophies for life. And then, so for example, you have someone who's like that, who's able to clearly voice what their beliefs and philosophies, what they want to, how they want their life to go, even maybe how they want their life to end. And then you have a family member who disagrees with that. Which one do you go for? Because there's clearly an element of the person of who they are that is retained, and they're clearly stating their wishes, even though for all intents and purposes, they're not cognitively capable to make medical decisions. And then you have someone.
That's something that we get called for at our institution, not frequently, because I think people are pretty supportive of their family overall, but it's something that's discussed on a regular basis within the ethics and palliative care community, that a patient can express, even a patient with dementia can express those long-held wishes, and and what's important to them. The classic thing is someone with dementia can still say, I want my son to be my medical power of attorney,
Right.
not my wife, because I trust my son to make this decision. And that's, they found acceptable for them to be able to sign the paperwork that they want that to be the case. The duty of the healthcare advocate is to provide the substituted judgment for the patient. And so if somebody is clearly not acting in the way that the patient themselves would have wanted, and that's clear to the provider, they can petition to have that healthcare advocate replaced. If the person is instead using their own values and judgments, or what they think is in the best interest, although the patient may have expressed wishes. Now, in practicality, doing palliative care, I've had no instances that I can think of where we sat down and sat with them and could not come to a decision or come to an understanding from the provider side of why the healthcare advocate was making this call that we thought was against the patient. So, with further discussion and even tempers and no judgment, we're usually able to get to the bottom of that controversy. But that is something that comes up regularly.
I like decubitus. I think that's kind of a fun word, decubitus.
Korsakoff syndrome and confabulation. People can look that up, but I've had several interesting cases with that.
Exomphalos, since you brought up the belly button, and that's a condition in which a baby is born with the intestines protruding out of the body, but covered by the umbilical cord.
Currently would have to be ECMO, which is an acronym, but it means extracorporeal membrane oxygenation.
Hemostat.
Hemostat.
It's like a little forcep kind of thing that we use. It looks like this, but has a curved tip. It all the time, and it helps us to dissect, and it's very, very useful.
But mine's Demodex.
What does that mean?
That's my favorite. Those are the follicle mites that live in your eyebrows.
My favorite medical word has always been contraindication, because it sounds so radically wrong in my head. It's like, how can you be a contraindication? Like indication is focusing, contra is against, so against focusing. I don't understand what's going on here. So that's always been my favorite.
Dysdiadochokinesis.
A favorite anatomical thing is the palato-vaginal canal, which is located nowhere near any kind of genitalia. It's in your skull.
Can you point to it? It looked like you were gonna.
I think it's somewhere. I from when we took anatomy, I think it's somewhere in the upper portion, and it connects the palate to the vaginal process or tunnel. Which so men have it.
I always liked apoptosis, cell death. I thought that was a fun word.
Endoplasmic reticulum.
So the question is asking about going against the demands of somebody in order to give treatment or save their life. Or what happens in the intensive care unit a lot is somebody wanting you to do things that you think are not medically justified because somebody has a terminal condition or impairment that's going to make death imminent for them. So again, this is super state dependent, but in the state of Illinois, there's a few different pieces of documentation that are helpful in guiding this discussion. And the first one being a healthcare durable power of attorney, which is pretty standardized state by state. So the healthcare power of attorney gives somebody the ability to make decisions on behalf of the patient when they're incapacitated, or when you're filling this out, you can even give somebody the ability to make decisions on your behalf starting immediately. So you can say, I don't want to make any decisions for myself. I'm 80 years old. I'm tired, I'm going to defer everything to my adult, this person, regardless of whether I'm incapacitated or not. So that's the first form that is relevant in our line of work, is picking a successor. If there's not a healthcare proxy identified legally, then the state of Illinois has a surrogate decision maker act that in a lot of states have something similar that stratifies sort of the order of importance by which we go down the line to pick somebody. So I think it goes appointed guardian, which if somebody has an appointed guardian, that kind of trumps everything else. Then I believe it goes married spouse. Then I believe it goes adult children. Then I think it's living parents. And then I think once you get past that, it's like other family members, aunts, uncles, cousins, and all the way down at the bottom, there's like a close friend. So if somebody has no family that you can identify, but they have like a roommate or something, or potentially somebody for whatever reason is not legally married, but has like a significant other, they can fall under that close friend exemption. If in a good faith effort, you have gone down trying to identify all of these people. Now say you can't identify a spouse, but you find an adult child. Okay, the adult child can make the decisions, but then if the spouse suddenly shows up and it's their legally married spouse, you then have to defer to the spouse. And this has happened a few times where, as you can imagine, it causes sometimes a lot of turmoil, especially if the family dynamics are not all positive with, maybe the patient got remarried and now they have a spouse that's not the biological parent of their adult children. It could get kind of messy. So particularly in an urgent or emergent situation, you do your best to identify the person closest to the top of the list. And then as more information becomes available, then you may shift who the decision maker is. Sometimes people claim to be legally married to the patient, but then it turns out that they're not. That happens somewhat frequently. If it really gets dicey, we can and will ask somebody to produce a marriage certificate or something. If there's multiple people, it's happened before. There's we've had it a couple of times with gentlemen in the ICU where their mistress and their wife showed up at the same time. And swear to God, I've seen it happen twice. It's very uncomfortable for everybody involved. We've had it where somebody's significant other is probably maybe a negative influence on them, whether it's with regard to substance abuse or how they take care of themselves. But maybe the significant other is the first emergency contact that we talk to and we have to intubate them or something. But later on, the adult children say, no, they're not married and we don't want that person up at the hospital at all. They're allowed to do that. So it gets very complex very quick. So if anybody's listening, pick your proxy if you're not legally married. And if you are legally married and you don't want it to be your spouse, then pick somebody else and put it in writing when you're young and healthy. Because if you wait till you go to the ICU, it could be a complete quagmire that we have to navigate through. So, okay, so you have your healthcare power of attorney. If one is not provided, you have to pick a legal surrogate or proxy. State of Illinois has a living will, like an active living will document you can fill out that dictates how you want your end of life care to look if you've been diagnosed with a terminal condition or something for which there's no hope of recovery. So the living will is where you can sort of get very specific and say, if there's no chance of me to recover and death is an imminent or a guarantee, I don't want heroic measures. I don't want a feeding tube. I don't want to be kept alive artificially on machines. I want my comfort maximized, all these things. And that helps us as the physicians, and it helps people's decision makers as the healthcare proxies know what this person wants and what would be in this person's best interest based on their wishes. However, if somebody comes in with a living will only and not a pulsed form, which I'll talk about in a second, that says, I don't want to be resuscitated. If it's just the living will, my understanding, and I'm not a lawyer, is that the family member can reverse their resuscitation status if it's just the living will. And me as a physician, I'm under no obligation to follow the living will legally. I can do things against what is specified in the living will, although nobody would do that. And we use this as sort of a guide to how to proceed with people. I think it may become more important legally if we as the healthcare entities make the case that somebody's surrogate decision maker is not acting within their best interests, and that goes to court, because if somebody's a healthcare power of attorney rather, and we think they're not making decisions in the best interest for the patient, the only way for them to be stripped of that title of healthcare power of attorney if the patient is incapacitated is for us to take that to court and have a court, like a judge, remove them as the POA. In that case, the living will might be very helpful, because you could say, hey, clearly this is what this person wanted and they're incapacitated and this is what the power of attorney is doing, and it's totally at odds with this living will. So there's that document. And then the last document, and I think these are called the same thing in most states, but I think that each form is state dependent, and it's called a POLST, which stands for Physician Order for Life-Sustaining Treatment. And this is the DNR that you'll hear paramedics talk about and hospitals talk about. And this is like DNR in big capital letters. So it's a form that the patient has to fill out. It can be filled out on their behalf by their power of attorney, but ideally the patient is the one filling this form out. And this form says that allows them to say full resuscitation, no resuscitation. You can get very specific and say, I don't want to have CPR or be intubated, but I am okay with medications to artificially keep my blood pressure elevated and keep me out of abnormal heart rhythms. And there's even a section to pick, I just want comfort care. So if I come to the hospital and I'm sick, don't do anything. Don't send me to the ICU. Just give me comfort focused care and let me pass naturally. So this form, it's a bright hot pink form in the state of Illinois. And this form is a legally binding document that cannot be reversed by the physician or the healthcare power of attorney or surrogate decision maker. So if somebody fills out this form, they don't want CPR, they don't want to be shocked, they don't want to be resuscitated, and then they are incapacitated, nobody in their family can reverse this form without the patient's consent. So if somebody is elderly and has very strong opinions on whether they want CPR or not, this is the form that we try to encourage them to fill out before it becomes a problem, because this is the one that cannot be cannot be altered and is applicable across the whole state. So those are sort of the four documents. Those are the four documents that we use to guide what we do. And these are the situations where if the patient and the patient's family seem to be at odds with whether they would want us to do things or not do things, we fall back on this documentation to figure out who is telling me to do this and are they even legally able to do that? Is this in accordance with what the patient wants? And is there some sort of very legally binding resuscitation order that we have to follow regardless of whether somebody tells us to or not? The most surprising reason a patient is denied treatment would probably, this is a couple sentences, bear with me, but I had a patient who came in and didn't get the COVID vaccine. And that's a whole side thing. But I said, why didn't you get the COVID vaccine? And he said, I don't want any toxins in my body. And the only medication this patient took was lots of systemic chemotherapy for cancer. So I kind of chuckled and I was like, it's just ironic because literally the only thing you're taking are very toxic things for your body.
Probably, I would say trust issues are a big thing. Like people just say, I don't trust you, I don't believe you. It's surprising. I've had one patient who didn't want to, or they wanted to actually get an amputation because of their leg, because they wanted to make a statue, a lamp, just like A Christmas Story. Literally a true story. And they did it. We supported it. Like it's a bodily autonomy and bodily rights thing. So again, she never picked it up.
Or I think having estranged family, so lack of family support and didn't want to be involved.
They would like to go home and smoke and spend time with their man friend.
I mean, like aliens. like I mean, I've had patients say that they don't want the injection.
He's in psychiatry.
Yeah, so like I've had patients tell me that they don't want an injection because the government or aliens are following them. So
having patients sign out AMA to leave and go do their extracurricular activities.
The obvious answer that comes to mind is just inability to pay.
Have been parents that, because of their religion, denied transfusions, and we've seen that, in the press over the years, and they have to get court orders and different things
for political reasons due to misinformation on the internet.
They just can't stay in our hospital anymore. They just want to get out. They want to take their kid home. And us being like, no. we got stuff to do first.
We had a family request early discharge because mom had to go to a wedding.
When you say that someone doesn't have the capacity to make decisions, when you say that someone is imminently a danger to themselves or others, and what does that mean, and how does that change? Those are kind of big ones that I face kind of on a regular basis, and it's interesting because it is actually not that set in stone, even amongst providers within the same group You can, I remember an instance specifically where there was a patient who said, I want to leave. And in my eyes, I didn't feel he was imminently dangerous to himself, and he was not thinking clearly, but at that moment, I felt he was okay to make the choice. And when I spoke to my attending, he said, "What are you talking about? He's clearly psychotic," which, it is not psychotic. People can be psychotic, but that's kind of one of those things. It really does. In psychiatry, I think more than any other field, you can let your inner paternalism can start kind of swinging around very easily. And it's also interesting because it varies from time to time and place to place. And what I mean specifically is, though, I just had a patient a few weeks ago who, on most days in I would say May through October, or any day of the year in Southern California or what have you, I would have been okay with having him leave the unit. However, he was showing, he was leaving the homeless shelter. He left his shoes because he thought they were radioactive. He was walking around outside, and it was December. And the weather was about to reach sub-zero, and there was a clear and present risk of him freezing to death. So in that month in Iowa, he clearly did not have the ability to take care of himself and keep himself from imminently dying because of his illness. So in that case, I had to, request for a commitment.
I often get requests to come up to the floor that Eugene works on, both in my role as palliative care provider and in my role on the ethics committee. I have to say, Eugene, that I find the most moral distress when I end up on your floor. That in trying to reconcile the autonomy of patients with mental illness is a difficult thing for those of us who don't work full-time with patients with psychotic illness or even substance abuse. Is it okay to let a person leave the hospital to go back home to begin drinking when they have advanced illness and are likely to pass away because of their advanced cirrhosis? And so I can understand this issue of looking at someone with chronic schizophrenia and saying, he's still able to make certain decisions within his schizophrenia. There's certain things you as a psychiatry provider can and cannot do for him.
Yeah.
And those of us outside, find some of those decisions uncomfortable.
Absolutely.
And so we regularly have to talk about those kind of issues with mental health patients.
So how do you see the balance between public health policies, specifically vaccine mandates, and respecting patients' autonomy? I see the balance here not necessarily being one specifically about policies and autonomy, but about social contracts. Primarily because obviously we all live in a society, we all live in communities, we all live around each other. And so we all have to take these steps that ensure some amount of safety for all of us to coexist together. And some of these come in the form of social conventions. Some of these come in the form of economic conventions. And of course, given the class here, these also come in the form of health and ethical questions. And so when I'm thinking about this balance between these two things, health policies and patient autonomy, it's about how do we coexist together? And this is where I think that the social contract tells us that we should take especially basic steps to ensure that we can coexist together in a healthy way and in an ethical way. And I think that's very easy to do with vaccines. It's in general a very easy process, especially with the vaccine that we've created for COVID. It's been free so far. And so that is a big benefit over those folks who maybe don't have insurance, who would have to pay out of pocket. And so vaccinating themselves becomes a penalty for this type of a social contract and the way that we interact with each other. The same thing happens with all sorts of other sicknesses. And that's why in the past, it's been completely typical for us to continue going to work or school while sick. And that's been one of the really nice parts, if you will, sort of one of the silver linings of the quarantines and the COVID situation that we've been in for the past, 3 years now, is that we're normalizing taking off when we're sick. We don't want to get each other sick. And so when I think about these sort of public health policies and patient autonomy, it's really as simple as, well, it's a tiny jab, it's a tiny stick. And unless you have some sort of a medical condition, which is extremely rare that you would have some sort of an allergic reaction to that vaccine, I think this is really a small step. It's a minor inconvenience to have that type of a social obligation to others and be able to fulfill it and coexist with each other. So I think those are very easy to do. You get, of course, when you get into bigger policies like quarantines and shutting down cities and things like that, that's obviously a bigger step. But again, I know that especially for maybe lesser income folks who then can't work, they're not going in. If their income is not guaranteed by the government or by their company, then that becomes a more adverse situation. But what we saw with COVID is those sorts of policies allowed us to produce a vaccine quicker than we've ever done before in order to quell much of COVID's ramifications. I think we could have done even better had we had consistent policies nationwide. But I think in terms of patient autonomy and vaccines, at least, I think that's a simple step to take.
So there's like a couple variations of the same question about like, and this is like something that gets brought up a lot in medical school too, because obviously we're learning at that point. So you're like kind of in that situation where you haven't done any of these procedures and you don't always know so much information and people are asking you these questions and you're really often faced with like how do I tell people the appropriate amount of information? What do I tell them? How many times have I done this procedure? So in regards to like the procedure question, like the way that we typically will say that is like, I'm learning, I'm going to be doing this with someone who's done this many, many times, and they'll be walking through this, like me through the steps. But you don't necessarily always disclose the number of times you've done a procedure, but you always say like, this is why your attending is here, right? That's why you're doing it with the supervising physician. And you can allow people the option to say that they don't want you there. So like as a medical student, especially on the labor and delivery ward, pregnant women would be like, no, you're not helping deliver my baby. You're not catching my baby. Especially if you're like, oh, I haven't done this before. They're like, no. You can watch. Sometimes they won't even let you watch. But you just have to kind of disclose that and then be respectful of whatever decision they make.
And a part about disclosure that we didn't talk about that I think aligns with some of the questions is like, if there's maybe a cultural difference, like a lot of times there's cultures where, the family member will be like, well, don't tell, my mom or my dad that they're sick and dying from cancer because that's, we want to know, but they wouldn't want to know. And that can be really difficult when it's a different culture than you are. And that's when, like Dr. Leff had said, really understanding and representing. So finding if it's for a religious reason or cultural reason, for finding someone, leader maybe from those areas, so I can come and talk to them to be like, hey, it's a really good idea to disclose this to your loved one for these reasons, so we can decide, how we're going to treat this, what they would want. And it can be a really hard time as a practitioner. And Dr. Leff said there's a lot of moral distress over things like that. So that's one thing that I think is really hard, and it takes a lot of talking and working through with the family about how to do those things. And it even happens in pediatrics. Parents don't want to tell the kids, hey, this is going on. So I think that there's a couple different ways that is really distressful and hard to work through. And then I think there was another one about conflicted about patient refusing treatment and wanting to die with dignity. Patients have the right to refuse treatment if they are, if they have capacity, they deem that they understand the situation and know the risks and benefits and the outcomes for everything, and then they have autonomy and they are able to express that. And I think that it can be really hard sometimes when a patient doesn't choose what you think they would want, and whether that means no treatment or treatment, it can be really hard. But it is something that they can choose, and you can choose anything. So I think it's really important to still, as long as they're educated, to respect them and say you can always change your mind for a lot of things, not everything, but for a lot of things, be like, you can come back in a couple of days or a few weeks and change your mind. There are some end of life conversations that are a little bit different, but that's kind of another sticky wicket.
So what is the geneticist responsibility in that instance? Is it all right for them to break confidentiality to tell their siblings because they're now at risk, or because that is okay in certain instances, like with HIV and with other things like that? So is a genetic disease something that is puts the other person at such a risk that breaking confidentiality is okay?
I feel like I would not, if I were a provider in that situation, I would not break the trust and confidentiality of my patient, knowing that unlike HIV, something like Wilson's disease isn't transmissible, and that ultimately a person might come to a point where they can share that information when they are ready. But I don't feel like I have an obligation to treat other people that are not my patient.
So why do we charge people to give birth to children? Because of capitalism. That's why. This is a very short answer, but it's the easy one, because of capitalism. Because I've worked in now 3 of the biggest healthcare systems here in St. Louis. I've worked for healthcare consultants worldwide, and I now own an urgent care. And so I get it. I've seen the book of charges. I've seen when a patient is charged $14 for an Advil, which makes no sense outside of the environment of the healthcare system. And so why do we charge people to give birth to children when there's such economic and societal benefit to having children? It's just because someone wants to make money off of it. And at the end of the day, too, I understand from the healthcare system's perspective and other healthcare providers, they also have to get paid, of course. But if imagine the amount of bloat that you could certainly imagine at the top of any organization, and then maybe triple it for healthcare, especially for nonprofit healthcare, which is somewhere that I've worked in the past. And they have to pay all of those people. Several healthcare systems, Catholic healthcare systems that I've worked at before, had private jets on call for their executives 24/7. And that is what giving birth pays for, unfortunately, in this society.
Yeah, I would say at the surges where we've had, COVID surges that are overtaking our hospitals, where we don't have the staff to take care of other patients, I definitely believe that I would morally use it as a vaccine status for priority, because at those points in time, we didn't have enough ventilators or hospital beds for other patients that were having car accidents and strokes and heart attacks and cancer, and they didn't have the resources or staff that should be caring for them. And that those with COVID and are unvaccinated are hospitalized for weeks, sometimes months, not only using ventilators and beds, but even like a resource called ECMO, which is an extracorporeal membrane oxygenation, and it provides cardiac and respiratory support and life support, but it requires multiple blood products a day. And so when you're using all of that blood for sometimes months, we've had patients for like 6 months on it. That's taking away blood products from those with cancer or needing mass transfusions or severe infections. And so those were times that I definitely felt like if you weren't vaccinated, you shouldn't have those resources.
Biggest moral failing would be not doing everything in their power to alleviate suffering as much as possible from a medical standpoint.
not supporting our most vulnerable.
Actuary tables.
Just read the testimonials in the last week about Paul Farmer. So this is his quote. "The idea that some lives matter less is the root of all that is wrong with the world." And I think that that applies with our healthcare.
The fact that people rely on GoFundMe's to stay alive.
Medical care being cost prohibitive.
Cost of medical care is ridiculous. And to be more, I mean, more specifically, that the fact that a relatively wealthy person can get treatment that a relatively poor person cannot.
I think just so much about our healthcare system, and that it's privatized and people can't get healthcare when they need it and they can't afford it. And the price of insulin, even just to start, there's a lot.
Profitability.
So really, I think obviously I can't focus on what I think is probably the biggest moral failing because I don't have an answer to it. I don't think anyone should be required to, go in debt for life-saving care. I don't think people should be walking around just buried in debt. Healthcare is not free. It has to be paid for, right? I think most rational people can understand that. The question is how. I think the thing I wanted to actually tackle was just kind of like the ethics of billing and how screwed up the whole billing this system is. And I think that to me is one of fixing the entire healthcare system and creating a universal healthcare system is so complicated, right? The system is built for one sort of, it's built for private insurance. And the fallout of just, you can't just flip that switch off. It's so complex that answering that, I don't know if anyone has the answer, honestly, that it's just so complex. But I think something that's maybe more approachable is just this inconsistency in billing, right? So billing is pretty much arbitrary. I mean, hospitals, particularly the hospital setting, predominantly in the hospital setting, in the standalone clinics, it tends to be more uniform and more reasonable. But in the hospital setting, services are pretty much just assigned a number, and it seems almost random, right? So there was a study like American Journal of Cardiology. I think it was like CABG, so coronary bypass, ranging from like $45,000 for the procedure to like almost $450,000 for the procedure, with a mean of like somewhere around 160,000. Huge range. It's like they just threw darts at a board. And basically the insurance companies that they have negotiated with have set rates of reimbursement. So they're trying to basically get as much out of these insurance companies as they can.
Right now in the COVID pandemic, this is a big issue that we've been dealing with. Our ethics program, we were responsible for drafting up our policy for critical care rationing in terms of ventilators, in ICU beds, all those kind of things. Luckily, we never got to that point. But one kind of technology that we regularly have to deal with this in is ECMO. The ECMO is extracorporeal membrane oxygenation. It's essentially like dialysis for your lungs. It takes your blood outside of your body and it oxygenates it and then puts it back in. And so this is obviously a big issue with COVID patients because when COVID patients, it ends up really affecting the lungs ability and it turns the lungs tissue fibrotic. And so it ends up being an issue where a lot of people need ECMO that are COVID. And I remember we've had several cases. ECMO is not it's not a destination therapy in the sense that it is not something that you can live on outside of the ICU. It takes very specialized care. Each ECMO person has 2 nurses, one that cares for their normal kind of care, like making sure they're clean, doing blood draws and all that kind of stuff. And the other person focuses just on the ECMO technology. And so it's a very expensive kind of care. It costs between $250,000 to $500,000 for every single ECMO run, for each patient. And then also it is something that is just very scarce. So like we have one of the largest health systems in Georgia, and we only have around 10 ECMO circuits within all of our hospitals. And so we have these kinds of cases that come up where someone will be on ECMO for, several months, 70 plus days, and then they're not making progress. And so then we have to come in and kind of help the team think through, well, is this something that we need to think about in terms of, is it still benefiting the patient? Because it's such a scarce resource, there's questions about whether it is ethical to unilaterally withdraw that and stop offering ECMO to that patient because it could benefit others. And so generally, at least in the Georgia context and in most contexts in the US, it's not considered ethically supportable to unilaterally withdraw a ventilator or other stuff from patients. There are certain circumstances where it may be, but on the whole, it's generally not in terms of actual withdrawal. Now that's different from withholding and, DNARs and kind of the passive euthanasia stuff. But ECMO is a unique thing because it's a scarce resource and because it's something that is so expensive and so beneficial to many people, and we just don't have the supply to meet the demand. And so we had one case in particular, I think this was one of the most polarizing decisions I've had to make. We had a case of an undocumented immigrant that was unvaccinated but got COVID and was essentially on ECMO as this bridge to nowhere. So essentially he was being sustained by ECMO in the ICU, but he wasn't able to make progress to where he could ever get off of it. And so that brought up this concept of futility, and then how do we reasonably and ethically ration these resources to people, because this is no longer in this sense benefiting the patient if they're never going to be able to get off of it. And so we ended up having to work with the team to provide some sort of guidelines and some treatment limitations for this person. He eventually, luckily, he got to the point where he got sick enough and made the decision on his own that he no longer wanted to be on ECMO and wanted to prefer a comfortable and peaceful death, no longer stuck to the ICU. But it was a really emotional and morally distressing situation for a lot of people, especially given the fact that this guy was in a vulnerable state in the sense that he was an undocumented immigrant. He was not a transplant candidate because he was an undocumented immigrant. He didn't have the insurance that a normal, U.S. resident would have. And so that was one of the areas where that we regularly deal with in terms of rationing and scarce medical resources. And I guess on that topic, we've had other cases where we've been pulled in to help the team decide between two different people who were up for ECMO rationale at that point, or who were up for ECMO consideration and evaluation. One in particular, I remember it because it was an older gentleman who had some sort of cancer. I think it was like a colon cancer or some other kind of cancer, but he needed ECMO for his lungs for oxygenation and everything. And then this was against a younger guy who had COVID and had an assault on his lungs from the COVID, and so that's why he needed ECMO. And they generally, the team couldn't really distinguish, which one would benefit more from it. They both had generally the same opportunity. I remember one of the docs came up to me and asked me, the older guy is vaccinated for COVID, where the younger guy is not vaccinated for COVID. And so how should that play into this decision? And so we had to kind of push back on this. I think with a lot of these things, there's a natural trend to pull towards those who are vaccinated. And there is something to that in the sense that they've done their duty. They've done their duty to protect society, to protect themselves, but also society, and to they're best situated to benefit from this scarce resource. That said, we can't, in individual cases like this, you can't really make that a determining factor because there's so much that goes into it. So like if you think about an African-American patient who comes in, let's say that they've been given their historical treatment of African-Americans in our country, particularly within the medical context, it's unfair to really put this on them because they may be more subject to this kind of fake news or this lack of trust compared to a white, wealthy person. And so there's this issue then about these decisions are never made in a vacuum. And so generally what we say is for using vaccination status for determining who gets specific goods of society, particularly medical treatments and technologies, it should never be on an individualized basis because we can never determine these things. None of these decisions are ever made in a vacuum. Now, that said, personally, I think some people will say that instead of not using it as a primary or first level criteria, that vaccination status could potentially be ethically supported as a secondary or tiebreaker kind of scenario. So if you had two, like the classic philosophers, how we do, you have two people who are exactly the same, and the only difference, they both would benefit 100 points out of 100 points from getting ECMO, and the only difference between them is one was vaccinated and one was not. Some of us, and I think you can make an argument for that could be a potential tiebreaker scenario. And I think you can use that kind of as a social contract kind of thing. Like they bought into this system and did something like this, reciprocal altruism. They did something, took a little bit of a sacrifice themselves to help society as a whole, but then it should also benefit them in back on the other end. And so I think you can make some sort of arguments with that in terms of how the COVID vaccine implies into this focus on scarce resource utilization.
So I'm just curious, what do you think is the utmost important principle or two to when you're trying to think of rationing schemes or triage?
Yeah, and so that's a good question. So when we think about it, like if we're, in the normal kind of individualized standard of care where patient rights and individual autonomy, that, individual autonomy rules all, we talk about the four principles kind of approach, autonomy, beneficence, non-maleficence, justice. They're supposed to all be equal and they all work together, but in reality, they don't. Individual autonomy is the first and primary principle because what the patient wants, if they have decision-making capacity, they get, essentially, in terms of they have absolute rights over at least negative rights. Whenever we think about crisis standards of care or whenever just stewardship of resources that are scarce in the medical context, benefit then really becomes the primary principle, maximizing benefit. And that can look at many differing ways. I mean, one of the things that they use is quality adjusted life years. And so how many years of life are you going to get out after this? It becomes sticky whenever you start thinking about things like quality of life, because then you get into issues with like disability ethics. And like, if you have somebody who is permanently on a ventilator versus someone who's not, but they both could potentially benefit in terms of like life years and being able to get outside of the hospital, how do you weigh that? So generally quality of life is not a consideration, but yes, absolutely maximizing benefits. And usually that's first seen in terms of life saved. Once, you get into like the second level criteria and stuff after that in terms of like quality adjusted life years, how old versus young is the person. Generally, we're going to give, whenever benefits are essentially going to be the same, we do want to prioritize the younger people, and in the sense of getting them more life years to experience. Like, so if you have an 80-year-old versus a 40-year-old, the thought is that if all else is being equal, you would prioritize the younger person because they haven't had as much experience through life. And so they should have a right to get through life a little bit more like the 80-year-old. But there's lots of differing considerations about that. The other aspect I do think that is probably the secondary principle compared to that is justice, and making sure that we're maximizing life saved, but we're not doing it by just saying, okay, if you're over 50, you don't get this because you're not going to maximize, the benefit from it, and only doing it. So you have to balance the maximizing the benefit and the life saved versus doing it in an ethically supportable way that's not going to bias against certain races or certain age groups or anything like that.
No, because then this makes it a very unequitable situation where people with access to, not that this isn't the case already to a degree, but the richest are going to be able to afford the best organs. So no, it has to be carefully regulated.
Okay, so from like an ethical standpoint, I guess you kind of have to say, yes, it is, because it's their choice, right? To sell their organ where it is. You have to respect the autonomy of the choice. But from so that's like an individual ethical standpoint, but from a like group ethical standpoint, no.
That's very hard. I'm going to say no. They should not be paid.
100% no. Too many unknowns for the donor later in life.
That's a tough one. My gut response to that question is no.
Should it be something that can be purchased? Kind of like, you know, people that are down on their luck, they give blood because they can get paid for it. I don't know. Organs are a different. I don't like that idea.
It's kind of weird though. We live in a capitalistic society, and you would think, oh well, it's just capitalism. But even capitalistic societies, they're even like, there's something wrong about that.
No.
I was actually asked this in med school interviews, and I think I say no. While I think it is a resource that I would like, you know, to see more of, I think ultimately it would turn into who has the ability to get by life without having to sell their organs to survive in our society. And I feel that it would become kind of a problem of the poor in our society. You know, as a physician, keeping in mind, like, do I need to convince people not to sell their organs?
I mean, that's a complex. I mean, should an individual be allowed to make that choice? I think yes. Should that be a thing that exists as a whole? No.
No, because it takes away the medical hierarchy of who's most eligible and most appropriate to receive them.
There's part of me that wants to say yes if you're willing to sell your organs, but then at the same point, why are you trying to sell? You know, are you at a financial part in your life where you're turning to that? Then no.
Yes, that would definitely allow increase the number of organs available and will help increase the overall lives saved.
I actually wrote my dissertation on this, so I can just give a brief understanding. I am very libertarian minded, so I'm very big a proponent for at least regulated compensated organ donation. And I think the biggest argument for the ethicality and the should be the legal permissibility of this is that we already do all kinds of stuff like this, you know, sperm, eggs, hair, all of these things are body products that are actually sold. But, you know, you think about these things with regard to when someone puts their life at risk in a job. So I think it was like lumberjacks or people who work on cutting down trees, people who work in certain police areas or in certain other mining or logging occupations. They have a much higher chance of death in their occupation compared to the risk of injury and the risk of death coming from nephrectomy, which is essentially the kidney donation. So if we're going to allow people to put their lives at risk for things like mining or logging or these other kind of things, why would we not allow someone to do that in terms of compensated kidney donation? Now, that's all to say, I think, you know, in a regulated market, you can justify this. I don't think, you know, like what you see in India and some of the other South Asian countries where it's a kind of a black market. I don't think that's appropriate. But if you look at Iran, they've actually got the only regulated system of organ donation compensation or essentially kidney sales in the world. And they actually no longer have a kidney waiting list for transplants. They have a kidney waiting list for donations. And so there's absolutely, yeah. And so it's really interesting when you look into it that I like to argue about this arbitrariness that we put onto this kidney sales. We do all this other stuff. We allow people to commodify their bodies in many other ways. So, you know, who are we to tell people that they can't do this? Now, again, like that said, there should be protections in place to make sure that those who are fully, very destitute, very poor, that they're not just making a bad decision or a not informed decision that are being coerced by their situation to do such a thing. But, you know, just like we have with end of life issues or death with dignity, having those controls and regulations set in place where people have to see a psychiatrist or they have to go through an informed consent interview to make sure that they're not being coerced. You can put those things into place, and ethically, it's hard to distinguish why we allow some of these things, but not this. there's no real good argument for why we do that. Oh, and then one last thing. We technically already compensate many organ donors, living organ donors. Most states, I think Georgia is going to be getting one soon, but a good majority, a good sizable portion of states in the U.S. already have something like a $10,000 tax credit for living organ donors who do that. So we're already doing that in some sort of way. They just fashion it as reimbursement rather than actual compensation. Because it is a little bit more of an expensive thing, but we're already doing it. So why do we have this thing whenever we're having, like, I think it's like 40 people die every day in the US because they need kidneys. Kidneys and liver lobes are both things that we can reasonably and safely do for living donors. And, ethically, I think we have an obligation to do that.
How seriously is the principle do no harm taken in the biomedical field? Are there scenarios when we don't follow the do no harm adage? And it's interesting. So like everything that we do, every medical intervention, whether it's a procedure or prescribing a medication, we're constantly weighing risks versus benefits. So optimally, everything that we do for a patient would sort of support as much benefit to the patient as possible and minimize the risks. So that beneficence, non-maleficence kind of seesaw. So we take it pretty seriously. I mean, we'll talk about this a little bit more down the line here, but doing harm in my specific line of work, where I've spent so much time in the intensive care unit, often comes down to doing sort of quote unquote heroic measures or sort of life-sustaining interventions when the patient has a terminal condition from which there's no hope of recovery. So where I encounter being tasked with doing potential harm the most would be trying to determine how to treat a patient in the setting when we know that they're likely to expire, and then what that looks like, and how do we maximize their comfort and minimize their discomfort when the script is sort of flipped, and now that we know death is coming, we're not trying to stave off death, we're trying to promote comfort. So I think that we take things like informed consent and necessity of procedures and interventions pretty seriously. So we certainly actively try not to do harm, and that's relatively easy when you have somebody who's younger, healthier, not having a terminal condition. It gets more challenging when you know that somebody's likely to pass away in a somewhat imminent time frame, but you have to follow your ethical obligations to the patient as well as their family, and your obligations to the law in terms of what the family might want you to do for the patient.
Yeah.
Essentially, I'm not necessarily in healthcare, but I have been in graduate school where research is done on animals, and I don't think enough people understand what it takes for a researcher at a R01 institution or even at a small institution to be able to do an experiment on animal. Oftentimes it takes approval of 2 to 6 months of writing, making sure the 60-70 page document is ready to go, basically saying how much of what anesthetic I'm using, what drugs am I putting on, what exactly, basically trying to describe any possible experiment that you can do. This then gets reviewed by a board. You have to, in that document, you have to describe the 3 R's of animal research is what they call it. Let me just refer to my notes: replacement, reduction, and refinement. Essentially trying to address, at least with a paper with citations even of why you have at least considered replacing the animal of choice to perform the research. So you have to say, okay, I'm studying respiration. I care about mammals because we are mammals, and we care about humans who want to improve human life. If you want to use a guinea pig or say a bird of some sorts, you would have to explain why that question can only be done in a bird. Well, the bird has a unilateral lung and it has an interesting circulation. And you have to have reasons why for basically everything. And then as far as the number of animals that you have to show the statistical power, and just basically trying to demonstrate that what you're trying to do will work and whatnot. But the practice is do no harm. A lot of these experiments, the investigators know that it does harm, but we make the strives to prevent as much as possible. So if your experiment causes pain, you have to have a pain protocol, a pain scale of how you're going to handle the pain and assess it and maintain it in a reasonable time, in a reasonable manner. So,
Yeah, it's the perk of the job. 10.
Yeah.
But I wouldn't be caught dead with them outside of the operating room or the hospital. I like to dress up.
Oh, I love scrubs. Scrubs are great. I don't wear them, but I wish I did.
Yeah, one pro of COVID, they let us wear scrubs to work.
Wait, you guys weren't doing that before?
We had to wear dress clothes in every unit except for the nursery and NICU.
Ah, okay.
Including the PICU. So you could be like coding a child in dress clothes.
Yes.
Absolutely.
100%.
Yes.
So like whenever I had to do it, I had to do like aseptic technique, where it's like you gotta put on gloves like inside out, and like that was always annoying and stuff. So that's not comfortable, but like the rest of the scrubs, yeah.
Okay.
I think when you're ordering genetic testing, you have to make sure you have a good question and why you're ordering it. Oftentimes, our biggest reason for ordering genetic testing is going to be to find out if they have a condition that has implications that could be impacted by intervention. So like, do they have, a certain genetic disorder that oftentimes leads to this, metabolic or nutritional deficiency? So we will treat that then. Or we know that the patient will ultimately require this therapy. So you start working towards that. And then part of what comes out of that information is family planning opportunity. And I think that is where it can be challenging when you're like using that as a reason to get genetic testing. I remember when I was working in a clinical genetics lab, one of the cases that was presented was a teenage girl who had kind of facial differences. And really, it didn't impact her life, her intellect, or her abilities, except for maybe some craniofacial like differences and maybe the ear, nose, throat difficulties that might come from that, as far as, maybe needing tonsillectomy and adenoidectomy, things like that, just because of her airway being modified or even.
And that's something you can tell from the genetic test, or that was a person you
So
saw?
I think it was a patient who had craniofacial differences. They decided to pursue testing because some of them maybe can have different outcomes. Or I don't even know, they had a discussion about finding a genetic answer. Usually when we have a kid who has kind of facial differences, we'll talk to genetics and they can look at the lab work, the imaging studies, and help point us in direction, say like, yeah, we think this kid has this disorder. The point that was brought up with this patient was that she was just a fine, normal, functioning teenager. And some people were fighting for a genetic diagnosis. And the question that the geneticist had was, what is that going to do for the family? At this point, we know what she has. We just might not know the exact mutation that she has. So how is it going to impact her care? And people said, well, maybe she would want to know for family planning. And somebody else raised the point of, so you're going to tell a 13-year-old girl that she doesn't want to have a child that looks like her. And that's like a big, I don't know, just it can be impactful in the wrong ways for children.
How often do you reflect and consider ethical questions in your line of work? Is it something you stop to think about often, or do you just go along with the protocols? I love this question because I do have not just this long employment background in healthcare, and mostly on the website marketing side, but I also took part in some ethical discussions. But I love this question too, because as of last December, my wife, who is a pediatric nurse practitioner, and I bought a pediatric urgent care that she had worked at for a number of years. And so this ethical background that I've had, being able to sit in on ERD discussions with ethical councils at hospitals and healthcare systems and interacting with those folks, I get to see on the front line the types of ethical guidelines that need to be used in patient care every single day. And you would think that maybe this doesn't happen as often in an urgent care environment because we see the patients for maybe 10 or 15 minutes and then we move on with our lives, right? But there is so much that goes into it. So first of all, obviously you're taking payment from the patient. One of the things that we do at our urgent care that many don't is that if we take your copay and any sort of payment information, but we end up sending you to a hospital because we don't treat that specific condition or because the condition is so severe that we can't treat it, we reimburse that cost. From an ethical standpoint, I think that's the right thing to do. And that's what you won't find in many hospitals and other healthcare systems. If one hospital treats you and then stabilizes you and then has to send you on elsewhere, you will get charged for any and all attempts to cure you on that first visit. And so it would be very nice for maybe a success sort of a based fee for especially some patients who can't really pay. And so because many of our patients are lower income, we just reimburse that cost and we eat the 10 minutes. It's not a big deal. Another thing that happened during the COVID situation that we've been in for the past couple of years is that oftentimes we'll find that our resources are scarce. And so it's very difficult for us to find COVID tests or flu tests or RSV tests. And then the tests are changing. Sometimes they're together and sometimes they're apart. And we get different reimbursements from different insurance companies depending on the test and their costs to us. And so, for example, with the COVID test, you have your PCR test. Those are given to us by the government for free. We can administer the test. We send it in to like Quest Diagnostics. They do the test, and then we get reimbursed. It's like 20 or 25 bucks. And none of that comes out of our pocket. Now, on the other side of the coin, we have rapid COVID tests, which were extremely difficult for us to find for a while. Those would cost us somewhere between $20 and $40 per test. And we had to buy, maybe $1,000 worth at the time. And we wouldn't get reimbursed for that test unless it was private insurance. So one ethical question that we had to ask ourselves was, well, if we have to eat that cost for low income or for Medicaid patients, should we just give them the PCR test, which is a good test? It's accurate. It's maybe even more accurate than a rapid test, but it'll take them 2 or 3 days to get the test results back. And is that the right thing to do compared to a rapid test result, which is more inaccurate, but they'll get the test within about 10 or 15 minutes. But now I don't get reimbursed for that cost. In fact, it'll for that patient, it'll cost me about $5. So what's the right thing to do here? And that's the big question for much of the healthcare system, not just for profit, but nonprofit, because at the end of the day, I have to make money too, and I have to pay my salaries, and I have to pay electricity and rent and things like that. And so from an ethical standpoint, it seems like I should treat every patient the same. But if I only have 100 tests and I know that I have 200 patients coming in and maybe 75 of those are Medicaid, then I have to make the decision about whether I should give those Medicaid patients the PCR test and have them wait 2 or 3 days. From an ethical standpoint as well, not only are they waiting, but they will get a more accurate test. It's free to them. But the other thing to consider too is because they tend to be lower income families, they may have to find childcare for those 2 or 3 days while they have to quarantine awaiting the results. So there are a lot of different ethical features to these situations that we really have to consider before we make that decision about what kind of test to give and what impact that has on the family.
Is it morally permissible for a physician to participate in the death penalty?
No, not by any interpretation of our Hippocratic Oath. Probably not, because there's a scarcity of resources and transplant ethics get very complicated. It's not something that I deal with, but if they've gone through the complete appeals process and they are certainly going to be executed, then it would be maybe prudent to save those organs for somebody with a longer life expectancy, much like we would if somebody needed an organ transplant, but they had terminal cancer or something.
No, because what's the point?
The Jacob Appel argument that says they should be. Oh, so you're familiar with it and you still
Yep.
say no.
I still say no.
Wow. Okay.
But I also have like a really weird, I have a really weird opinion about the death row. So.
Okay. Yeah, everyone wants to, talk about, oh, physicians shouldn't be a part of it. I'm like, we know. That's not the question.
Sure. Yeah.
Not death row inmates, but inmates in general should absolutely be. But if there's a time limit on them in terms of an endpoint, I would say that's probably not the best use of our resources.
Yes. Oh, that's so hard.
I think that they should be eligible to be listed. But the question is, like, if a kidney becomes available and where are they at in their death row sentence? Like, are they, like, what if they're a week away from being put up to death? Like, do you take them for their kidney transplant? I think that's a really challenging question.
No.
See, yeah, that's exactly. So I'm pro-life. Okay, so, but that means that I'm against the death penalty. And if I'm pro-life, and this is, well, I don't want to pontificate, but this is one of the problems I have with my own denomination, is because being pro-life also comes with responsibility of seeing value in life, even though I struggle with, are they valuable, period. Life opportunities should be accessible for all people, even if they squander it, even if that one person squanders it.
And I applaud what you say, Patrick, but even taking it out of a person on death row, and you have 10 qualified candidates who have all led a good life, they're not all going to get the organ. Sure, they can be on the list.
I think that is difficult because I don't love the concept of death row, but I think knowing that it's a finite resource currently in this country, I wouldn't be able to justify giving it to someone that we know will be put to death.
No.
Yes.
No.
With euthanasia, and I don't know all the ins and outs and the legalities and everything else, but and one of the questions had to do with a younger person. How would you feel about a younger person deciding that they wanted to die? And I think that there's a lot of psychological testing involved, because the splitting of the hair is, are they just depressed about, I guess that could be, but then look at what they're facing, sickle cell disease or some really crippling degenerative type illnesses that given going through all the hoops that they need to go through to prove that they know what they're talking about. I don't know if we have a right to take that away from them, a peaceful death.
Yeah. So definitely hefty, but in Colorado, we currently have the Illegal End of Life Options Act that happened in 2016 and is passed. That's for anyone over the age of 18. But in Netherlands and Belgium, they allow for children greater than 12 to be euthanized. They get psychologists involved and other medical providers involved, and they talk about what they're doing and how serious it is. I do believe that I focus on quality of life. And I think if there are children that have terminal illnesses and they're suffering, they're depressed, they're lonely, they're always in the hospital, they're actively dying, I do believe that they should be able to request euthanasia. And I know that's very controversial. But I've had a number of experiences with patients throughout the last few years, particularly oncology patients, but also patients with severe autoimmune disorders, that they're depressed, they're suffering, they're always in the hospital, they're in the ICU, they're not able to graduate from high school, they're not able to do homework, they can't spend time with friends and family, especially during COVID-19, our visitation rules and stuff. And so they want to die. And I think if there's someone who wants to die and they understand what that means and they have no quality of life, that I think that's appropriate. And we did have, she was 20, but we did have a patient within this past year that I took care of that was in the ICU a lot, and she had an autoimmune disease, and she was just progressing and progressing, and she graduated from high school online and was just like, I'm ready to die. And the day she said that, we actually, I don't know if we like euthanized her per se, but she did die that night. I think her body was just ready. And I don't know, I support that. I support quality of life.
So I guess oftentimes the way that we handle this, I'm a pediatric resident and I work in a residency program that has a huge cardiac program attached to it. And so in that instance, we have patients from all over the Chicagoland area who come for our care, including patients who are Jehovah's Witness. And a situation we come into a lot is parents who say, I do not want, or I will not consent to giving my child a blood transfusion. That is a requisite for kids going to the OR for cardiac surgery. And so there's usually, I haven't been a part of these conversations, but as part of the team and one of the people who's ordering the tests and ordering the blood prior to the OR, the discussion that's had is, that's okay that you, the parent, are not consenting, but if you would like your child to go to the OR for this intervention, then we will take custody emergently if we need to, and the child will receive blood. And I think that on a bigger scale has come up in a family who has, kind of going back to genetics, a family that we've treated multiple of the patients in the family, and they have a inherited cardiomyopathy. And in that case, by the time the patient is 5 years old, their heart muscle doesn't work anymore and doesn't pump effectively. And kind of, yeah, doesn't pump heart or pump blood out like it's supposed to. So early on, you do interventions that don't require blood, you use medications, you do testing, you do all of that. The challenging part for this family, and something that a lot of residents struggled with, was that 2 children in this family passed away because the parents would not pursue a heart transplant due to concerns that, you know, there is blood included in a heart transplant. So then they were offered the opportunity to pursue maybe a bloodless heart transplant, and they declined for their 2 children. This is, you know, back to back. I was around in my program when the second child was going through these kind of decision-making situations. They said if there was a chance that they could get a bloodless heart transplant, they would not want to pursue it, given the risk that they would need blood in the future in further interventions. So a lot of people in my program really struggled with this, including me. I didn't take direct care of the patient, knowing that this family had already lost a child, chose to have another child, and will not intervene on this condition because of their religion. And kind of being like, well, we, the hospital, take custody all the time when we need to, or, you know, we consult our child protection services, whether it's statewide or on a hospital scale. How come we can't do this for this kid? And of course, ethics was very much involved in just determining their case. I think the thing that surprised all of us was when the 3rd child presented in heart failure, and ultimately they did pursue the bloodless transplant at an outside facility. And I think it left a lot of us thinking, why now? What made you change your mind? How come you let 2 kids die and this one live? And I think it's hard for us because we see the times that we fight with parents to ultimately give interventions and how we kind of didn't win this one, but also like, is it our place? It's hard. It was really challenging knowing that, like, these kids weren't consenting adults. So the decision was made based on the parents' religion. But parents refuse treatment all the time. This one just had like a really awful outcome for the other two. From what I understand, the older sibling is, or the third sibling is doing well now.
That's good to hear. Yeah, that is tough. That is, yeah, the weight you feel afterwards, or the weight, just, yeah, carrying that around with you, whether that, because you guys didn't do anything wrong. You tried to help, you tried to inform them, you tried to do what you could do, you did all you could do, and they denied it. They, like you said, they passed away, and that's sad. And then it happened again. And like, I don't know, I mean, like, yeah, why now with this third one? But at least like, I was thinking like, thank God they finally learned, like, but yeah.
Yeah, I think it was, most of these conversations with the family were way above us. Like we weren't involved, and it was, you know, cardiothoracic surgeons and cardiologists having these conversations. But it was hard because it was like, it's not like a cancer that we're treating and the kid is miserable and there is, you know, limited hope. And so palliatively, you make this decision to not pursue any more treatment. But this is like, but we have an answer. We could do something. We're not going to do it. And it's hard as like a caregiver to be able to step back and be like, this is their life, not mine. And they're making a decision for their family.
I was thinking when you were talking about like these, oh, we have an answer for this, like all the COVID people, like that's all I could think about. That's why I chuckled.
I said, I was really sad this like late December, early January, knowing that we have an answer for this. One of our family friends was 18 years old when he passed away from COVID, before the vaccine was created. And I had the opportunity to see him in the hospital when everything was locked down, because the pediatric consultants were still seeing him. He had ultimately gone to the adult units for ECMO because of his, you know, adult size, basically. And so it made me really sad on Christmas when I admitted a girl with COVID who 3 days later was on ECMO in the PICU. Just thinking like, sure, we can say adults, you had your chance, but it really hurt that kids are still seeing the side effects of COVID because some parents aren't educated enough to pursue the decision to vaccinate or just are choosing not to vaccinate.